Colorectal cancers update for primary care. I'm Amanda Arrington. I'm a surgical oncologist here at the Med Center, Houston Methodist. We have a fabulous group of presenters today for you. A little bit of housekeeping notes, questions for speakers. Please submit your questions in the chat box on the live stream page. You may submit questions at any time during the presentations. We'll probably get to the questions at the breaks, so at the 10 o'clock break and at the end. And disclosure information. This information can be reviewed within the description area of the live stream page. You can expect to receive an email from Houston Methodist CME within 2 to 3 business days to complete a survey that will prompt you to receive your certificate. So again, welcome. The other moderator today is Dr. Nestor Espinola. He's the division chief of surgical oncology here at the Med Center as well, and surgical oncologist who asked me to present, to put this together. Again, our panel of speakers, Dr. Manisha Singh, Dr. Mayan Abdalrahim, our medical oncologist here at the Medical Center. Dr. Neha Mather is a gastroenterologist. Dr. Andrew Farrick is radiation oncology. Dr. Eric Haas, one of our colorectal surgeons. Dr. Mohammed Khalil is at the Woodlands for medical oncology. Dr. Hawk is a radiation oncologist out, I believe at Woodlands, right? Or at West. And then Dr. Diego Marinas, who's the colorectal surgeon at Willowbrook. Here's a brief description of our agenda. We really want to present for you guys the basics of colorectal surgery and any updates on treatment and what you'll see in your patients and what you can help your patients through once diagnosed or once treated for colorectal cancer. So, to know you have colorectal cancer, the first thing we have to do is diagnose or screen for colorectal cancer. So we've asked Dr. Mather to give us a talk on screening and risk factors.
Okay. Hi, I'm Neha Mather. I'm one of the gastroenterologists here at Houston Methodist in the Medical Center with the Underwood Center here for digestive diseases. So my topic, let me see if I can. Okay, thank you. My talk today will be about the colorectal cancer, specifically focusing on risk factors, screening methods, and any other recommendations from a GI's perspective for our primary care doctors. So first of all, thank you, Dr. Arrington and Dr. Espinola, for inviting me, and thanks to our primary care doctors who are our kind of gateway to some of these methods and to getting them to providers like GI doctors, oncologists, and surgeons. So we're going to talk about basics of colorectal cancer, risk factors, screening methods for primary care providers, and any recommendations at the end. So why should we really care about colorectal cancers? It is one of the most common cancers in the United States and in the world, and third most, and the cause of mortality as well in both men and women. Per our most recent guidelines in 2020, NCCN, we saw it is the third most common diagnosed cancer, and second in mortality. About 104,600 new cases of colon cancer in the United States, about 43,300 new cases of rectal cancer, and 53,000 deaths per year in the United States. Half of these cases could be prevented by just improving modifiable risk factors. And, sorry, I'm just going to use the keyboard here. And the only cancer that we can actually prevent mortality by screening tools and surveillance using things like colonoscopies in average risk patients. So I think there's definitely room for improvement in this, and that's what we're going to talk about. So again, I wanted to emphasize it does affect both men and women. So 1 in 23 in men and 1 in 25 in women. This is just some schematics from the WHO database that's showing the the incidence and the prevalence of our colon cancer in both men and women. This is all, both sex combined, all ages, so colorectal cancer about 10%, and then the mortality and death, you're looking on the right side of the chart, about 9.4%. So this is more zoomed in on the North American database. So we're looking at about 180,500 new cases in both sex, and you're looking at a cumulative risk for men about 3.38%, and then for women 2.61. And the mortality for men, again, in the United States, we're looking at 1.05% and 0.7 for women. So again, why it matters is because if we can detect it early on, we can make an impact for survival for our patients. So local regional cancer, about 90% 5-year survival rate, local regional, about 71% 5-year survival rate, and distant cancer, more metastatic, lower, 14% 5-year survival rate. And the incidence and mortality of colorectal cancer is rising. However, in the younger population, however, we have made some impact in overall the course of this disease. From the 1990 to 2007, about a reduction of 35% in incidence and mortality. And in 2017, mortality was down from peak rates of 53% in men and 57% in women. And most of the credit of this goes to improvements in advances in prevention, early diagnosis, and screening. 63% of the colorectal cancer deaths were attributed to lack of adherence to current screening recommendations. So very important that we have our primary care doctors along with us in promoting these types of preventative health care. As I mentioned, the rise in the younger population, less than 50 in adolescents, about 2% per year since 2003. We don't really fully understand why, but some of the thoughts are that these are mostly sporadic, and they're linked with some of the diet and lifestyle risk factors, which I'm going to go into a little bit. So the goal for our National Colorectal Roundtable Committee is to increase the U.S. colorectal cancer screening rate to 80% in every community, and to bring it up to a higher rate. And by that, we're going to reduce 280,000 new cases and 200,000 deaths by 2030. So hopefully we can all accomplish this together. So risk factors. So the most common risk factors, I look at it as modifiable and non-modifiable risk factors. So modifiable, what you can help your patients is diet, obesity management, physical activity, alcohol, and tobacco, which we probably know are linked with many, many diseases. Things we can't control ourselves always are our family history, genetics, hereditary syndromes, inflammatory bowel disease history, our race, ethnicity, and age. So our thought is that factors like lack of, more sedentary state, lack of physical activity, non-Mediterranean diet, high consumption of red meat and processed meat, diet low in fiber, and alcohol and tobacco use create an inflammatory condition in the colon and affect the gut microbiome that over time then causes changes to lead to early onset of colorectal cancer and advanced neoplastic lesions. So diet-wise, what we do see in some studies are diet high in fiber, legumes and soybeans being one of the better ones. Fish, vitamin D, calcium are associated with decreased incidence of colorectal cancer, and foods high in red meat, fat are thought to cause epigenetic and genetic changes in the colon, resulting in genomic instability. So they've seen studies with the red meat and processed meat can increase incidence anywhere from 10 to 37%. And what the thought is that these processed meats can contain nitrates that causes bacterial degradation and fermentation, and thus forming these products called NOCs, or N-nitroso compounds, that attach to the DNA and then cause mutations of the oncogenes and tumor suppressor genes. So I know this may come a little bit small, but I'll go through this. So what are the benefits of fiber? So the colored schematic on the left, it increases fecal bolus, and so thus it reduces the carcinogenic substances dilutes it in the gut lumen. Other benefits is thought to that the bacterial fiber fermentation produces small chain fatty acids, or SCFA, and that leads to a blockade of conversion from primary bile acids to secondary, which are more toxic. And also the small chain fatty acids reduce cell proliferation and facilitate apoptosis. Other benefits is it shortens the transit time, so it reduces the carcinogenic substances in contact with epithelial cells. And lastly, it delays absorption of complex sugars, so that's reduction in postprandial hyperinsulinemia, which can also help with the obesity management. So the data is, good and bad on some of these studies. So there's a chart that was put together about convincing, probable, and limited data evidence with the risk factors and decrease in risk factors of colorectal cancer. So as far as increased risk for colorectal cancer, good convincing data is behind red meats and processed meat, body fat, abdominal fat, and in men, alcoholic drink. There is probable data evidence for women with drinking excessive alcoholic drinks. There's limited but suggestive data to support foods containing iron, animal fats, sugar, and cheese that can also increase risk of colorectal cancer. And lastly, there's limited, but there's no conclusion on increased risk with some fish, glycemic index, folate, dietary patterns, vitamin C, vitamin E, and selenium. The good convincing data behind decrease and reduction of colorectal cancer is behind dietary fiber, which we talked about, and there's probable benefit from garlic, milk, calcium, and there's limited but suggestive evidence behind fruits, non-starchy vegetables, and vitamin D. So the gut microbiome is also another hot topic, and we've been looking at this for a long time now, but the research is still ongoing. It's a complex environment in our gut containing bacteria, fungi, and viruses, and they communicate with the host, which is our human body, and us, and provide epithelial defense against pathogens, accelerate maturity of the immune system, absorb nutrition, and ingest food, absorb nutrition from ingested food. So it was first described by Dr. Weisenberg and colleagues, and this was looking at the correlation of colorectal cancer and Streptococcus bovis. We do know that there's an increased risk of that and correlation. And then further studies have shown some evidence around Fusobacterium and enterotoxogenic Bacteroides fragilis in colorectal cancer specimens. So we're still trying to see how we can further know these targeted bacterial organisms and environment, and how we can maybe predict better in the future who might be at risk. So how that works is that on the far left side, you have the microbiome, which is healthy, and in normal conditions, they will detect through the receptors, toll-like receptors and nod-like receptors, which are TLR and NLR on your left side. And basically, these receptors will realize if there's any kind of pathogens. They're kind of looking for signals from pathogens, and then they turn on the further immune response and then activate through the cascade cytokines to basically stop the bad bacterial destructive causes through the immune system. But if we have a change in the microbiome, these like Fusobacterium, et cetera, pathogens can invade through the mucus layer and invade into the stroma and destroy the tight junctions, and thus affect the DNA and cause carcinogenic changes. Now, this is a very busy slide. What I just want you to get out of this is that obesity and colorectal cancer, there's a huge link, and we're really looking at this. I think it certainly is linked to many cancers, not just colorectal cancer. So what our thought process behind this is the obesity causes dysfunctional adipose tissue, which then leads to chronic inflammation, metabolic syndrome, and insulin resistance, and factors like adipokinin that can further cause downstream effect of increasing different signals like VEGF, resistant adiponectin, and those cause further angiogenesis and invasion of cancer cells. So we do know dysbiosis can also promote some of the inflammation and microbiome changes. So bariatric surgery is positioned in some of these cartoon pictorial to combat some of our patients who absolutely meet criteria for weight loss that way. So keep that in mind. There's been talk about aspirin and prevention of colorectal cancer also, and there's some evidence behind this, But the USPSTF task force conducted a systematic evidence review of trials to assess impact of aspirin and on total cancer mortality and incidence in persons eligible for primary prevention of cardiovascular disease and colorectal cancer mortality. So the 20 trials that they compared aspirin, which is baby aspirin, 81 milligram versus placebo or no treatment, was looked at ages 40 and above. And they saw in cardiovascular disease prevention trials, there were 4 trials and of 14,000 patients. But 20 years later, colorectal cancer mortality was decreased in these patients receiving aspirin. So this is for the long haul. This is not an immediate benefit that we're seeing. And then 3 trials looked at about N of 47,000 patients, aspirin and reduction of colorectal cancer. And again, you saw benefit 10 to 19 or 20 years down the road. So again, this is a maybe recommendation. This is not a strong evidence recommendation of baby aspirin as a potential prevention and in preventing cardiovascular disease. So if you have a patient who has cardiovascular risk factors of greater than or equal to 10%, 10-year risk, and are older, like 50 to 59 years of age, and don't have increased risk of bleeding or a history of GI bleeds or the complications from bleeding, and have at least a 10-year life expectancy, then you can consider adding something like this. So what are our screening methods? The first I want to say, what is a good screening tool? You want to have a good sensitivity to make sure you have a true positive rate. You also want to have good specificity, true negative rate. Accuracy of the test is very important. If you get false positives, you can lead patients to have anxiety while they're waiting to have further testing down the road. You can lead to over-testing and also increased follow-up. So we want to find the right fit. And also, a lot of these patients are asymptomatic when they come to your office to have a discussion about screening. And so you want to find a test that they will adhere to, which is important, and not be a barrier and delay their care. So this is kind of a nice summary chart. I felt like compared all of our screening modalities. So the top one is colonoscopy, which is still the gold standard that we talk about. And the premise is that you're having direct endoscopic examination of the entire colon. So you can see lesions and in real time take them out. So the sensitivity is really good, greater than 95%. And in the best case scenario, if it's a good or negative study, you can get a lot of mileage out of it, so 10-year follow-up. And advantages, like I mentioned, high sensitivity allows for visualization of the full colon, and you have both distal and proximal colon visualization for lesions, and you can remove it as you see it. Limitations, as we all know, it's invasive. You have to do a bowel prep, which I'm going to talk about in a little bit. And so that can be difficult for some patients, requires special facilities, not easy access, cost associated with it, sedation, anesthesia risk factors. And of course, there's risk itself with an invasive procedure like perforation or bleeding. A sigmoidoscopy has kind of gone out of favor now as far as the screening modality, mainly because it only looks at the distal colon. It still has a great sensitivity looking at the distal colon only because, again, it's similar to a colonoscopy. You're getting direct visualization and removal of any lesions. But again, it's only looking at the distal colon, so you can miss 2/3 of lesions in the colon. And this does not give you as much mileage, so you're doing it every 5 years, but you have to do it in conjunction with another stool test. So I really don't, tend to do this unless somebody has a surgical colon where they only have the left colon left, so then this would be something appropriate. And it is semi-invasive. Again, the bowel preparation is still involved with the sigmoidoscopy. Again, it requires a cost and facility accessibility, and there's always safety concerns because it still may require sedation and be invasive. CT colonography is it's still invasive, but another modality that our radiological colleagues provide. It's another name for it is virtual colonoscopy. It has good sensitivity, about greater than 90%, but again, you have to do it more frequently every 5 years. And it does allow the full visualization of the entire colon, not just the left side like a sigmoidoscopy. But no sedation is required, which is a benefit. And but the downside is it's still invasive. You're inserting a catheter in the rectum to insufflate the colon with air, and that can be sometimes unpleasant. You still have to take a bowel prep for the cleaning out of the colon. And again, you have to have a facility that can have these tools. So accessibility is again an issue. And you cannot remove the lesion. So this is where things start to kind of have limitations in screening. So if you find something abnormal, you have to then have a follow-up colonoscopy. So then leads to more cost, and also sometimes insurance does not always cover this. So our stool studies are next. The next three, fecal occult blood testing that's been around for a very long time, FIT, which is immunochemical detection in the, of hemoglobin in the stool, and the multi-targeted stool DNA test. So the occult blood test does not have good sensitivity because it's based on just hemoglobin detection in the stool. So it can be exogenous as well if somebody's eating like animal ingested hemoglobin, and so it can lead to sometimes over-detection, which may not actually pan out to have an abnormality. And it has poor sensitivity, 33 to 75% to high range, but on the lower end compared to the other screening modalities. You have to do this annually, so again, that limits us because patient follow-up is poor when you ask them to do something annually. This is, more onus on our primary care doctors, and we can have patients fall through the crack. And again, but the benefits of it is it's easy, accessible. Everybody can do that in their office. It's not invasive as much as the other procedures. Low cost, and it does detect lesions in both ends of the colon. But again, if something is positive, then again, you're leading to a follow-up procedure from there. So cost, again, accumulation. So our immunochemical detection of hemoglobin in the stool, the FIT, is a little bit better in its sensitivity of 60 to 85%. Again, you do have to do this annually, but again, just like the FOBT, it's accessible, it's not invasive, it's low cost, detects lesions on both ends of the colon. And again, it's poor detection because you're just not finding lesions at an early stage. You're by the time there's hemoglobin in the stool, it can have an advanced lesion, so you're missing some of the precancerous lesions that are not bleeding, and you cannot remove it. So if something is abnormal on these tests, you're then having a secondary follow-up for patients. So the multi-targeted stool DNA test, again, is much better. It's we call this the Cologuard, which is the only, I think, brand out nowadays. It's a much better sensitivity of 92% or 93% listed. But you do have to do this every 3 years, so not as bad as annually. It has much better sensitivity. It's accessible. Patients fill it out, form, and it's mailed to your house. So, it's not something you have to go to the doctor's office. It comes directly to you. It's not invasive, and the detection is still on both sides of the colon for lesions. It's better than other modalities, but again, if something is positive, we're then having, again, a follow-up procedure like a colonoscopy. So it cannot remove lesions at the time of detection. So because of the benefits of colonoscopy, where it's real time, you can remove things, and the mileage you're getting over 10 years if things are normal, this is still recommended as a gold standard for screening. And I really don't recommend sigmoidoscopy, CT colonoscopies as much, and FOBTs. Now, there's always, the right patient for each of these tests, but I would urge you to consider having a discussion about the more sensitive and impactful tests, which would be like a colonoscopy, and then a Cologuard could also be to follow that, and FIT, I would position that lower. So this cartoon on the left kind of helps us to see the pathway for cancer. You have healthy bowel on the left side, and that progresses to then hyperproliferation of the lining, leads to small lesions like polyps, and then go into larger growths, and then further down become dysplastic, creating our smaller localized adenocarcinoma cancer in the colon, and that further, if it's left alone, continues to proliferate and invade, become metastatic. So there's two pathways pathways to this. You have adenomatous and serrated pathways, and I'm sure there'll be more talks about this further down in our day. But there are different gene mutations that go along with different pathways. So typically our adenomatous pathways, we're having mutations in the APC gene, and as the process continues, you have further mutations, KRAS and P53, and then in the serrated pathway, it's more the BRAF mutations. And when you look at in the bottom part of this cartoon, you're seeing the different tests and where their benefits are. So colonoscopy, you can find healthy tissue and go all the way to invasive cancer. You can detect at all stages of this process. So it's benefit to use this right away because it can help you at any stage. Sigmoidoscopy, again, only in the left colon. You can see it at all stages. So the limitation is the amount of colon you're looking at. CT colonography does help you throughout all stages, and then occult blood testing and FIT stool testing is only for more advanced lesions because you're banking on the fact that we're seeing some hemoglobin or blood in the stool. So earlier lesions or healthy patients you cannot differentiate because they may not bleed. So the multi-targeted stool DNA is helpful at all stages, so that's why we do not recommend the FOBT and the FIT as much. On the right side, you see some endoscopic pictures from colonoscopy. So in the top left, you're seeing more flat, sessile serrated polyps. This is, you can barely see it, but there's a carpeted lesion there. And these are the lesions that we were missing, for a long time, and it would lead to interval cancer between colonoscopy. So our society has become a lot more aware of these and how to detect it. We've got adenoma detection rates where we are taking our time to go through the colon, not zipping right through it if we don't see something big. So these are all technical things that our society has improved to help the screening potential. And on the right side of that, you see a more traditional, more pedunculated polyp that is more adenomatous. And then if we leave these two lesions alone, what grows is the colon cancer picture below. So we kind of talked about the two modalities of precancerous types of polyps, the adenomatous and the sessile serrated polyps. And I'll get to this in a minute, why that's important. The risk of adenomatous polyps to develop into colon cancer increases with the size of the polyp. So only 10% of advanced adenomas, which are greater than or equal to 1 centimeter or greater than or equal to 25% of the villus component or high-grade dysplasia seen on histology, become cancer. And of the colorectal cancer, 60 to 70% of the colorectal cancers develop from adenomas, and the remaining 25 to 35% come from sessile serrated polyps. So again, shout out, because I'm a gastroenterologist, for colonoscopy because of the benefits. And therapeutic, it's diagnostic and therapeutic at the same time. We talked about the time-consuming prep issues, the risks, and anesthesia. And if done in a good, well-experienced endoscopist's hand, in a good bowel prep, meaning clean colon, not having stool obscuring our view, we can have an impact on the patient's outcome. And just as a reminder to our primary care doctors, 45 is a new starting age of screening and not 50, so 45 is the new 50 as a reminder. So bowel prep is one of the biggest, I think, barriers that you guys probably hear in the clinic, and so do we. And so what can we do about that? So I want you guys to know that every colonoscopy has to be tailored to the patient. There's no one size fits all. The bowel prep has to be discussed. So if you have patients who are hesitant, uncertain, or if you have patients who are have a difficult prior experience, did not tolerate it well, didn't have a good clean out, all those limitations, it's time to send them to our clinic to have a discussion. Instead of going through an open access, just meet the day of your procedure, you get the standard prep. There's a lot of advancements in the bowel prep as well, and how we do them and how we can tailor them and modify them for the patient's benefit and outcome. So, talk to your gastroenterologist about options so we can tailor it. So I want to mention that there's a new kit on the block. It's called SUTAB. It's a tablet-based bowel prep that came out last year, FDA approval. Majority of our preps have been liquid solutions, so taste has been a big, kind of limitation for some patients, nausea, gagging, that kind of problem. So we've come a long way with the liquid. We've had low volume bowel preps that have come in the last years, and that's really also improved. And in our hospital, the main method is we're using low volume bowel preps for hospitalized patients, not necessarily Go Lightly, which is the 4 liters standard that used to be around. So Sutabs is corollary to another brand called Suprep. It's a sodium sulfate, magnesium sulfate, potassium chloride solution that's in a tablet form. So the key is that there are 12 tablets that you swallow, so it sounds like a lot, but for some patients this might be the best fit. And they have to swallow one tablet at a time over about 15 minutes, not all 12 at once. And you do have to chase out with quite a bit of volume, which is 16 ounces of water, but that is water at the end of the day. It's not a flavored medicated solution, so that sometimes it's tolerable for our patients. And then you have to do a second dose 4 to 6 hours later, similar 12 tablets followed by the 16 ounces of water. So again, pros to this is it's a tablet-based. Cons are it can still create nausea. It's a concentrated solution, and it can cause cramping. So a lot of times we provide some antiemetic pills to go along with the prep, just to give it to the patient, arm them, so in case in the middle of the night they're having nausea, they can take a tablet of ondansetron and get through the prep, so they can still get their screening done. So I want to make sure that I do separate screening for colon cancer versus diagnostic. So for primary care doctors, I see this all the time. Sometimes we get patients who come through open access pathways to us for screening, but they have symptoms. So these are the patients you want to identify ahead of, separate them from your average risk screening, no symptom patient. And you want to identify red flag symptoms like rectal bleeding, abdominal pain, weight loss, melanoma, iron deficiency, and changes in bowel habits. And you want to triage them sooner than later to a gastroenterologist or the right next step for them, whether it involves radiological imaging, blood test, and whatnot. And we want to close this loop sooner than later so we can detect things early, not have them sit in an inbox for a doctor to get to schedule maybe 1 or 2 months down the road. So the other update I want to remind our primary care doctors are follow-up interval reminders of colonoscopies on patients who have had polyps on their initial colonoscopies or prior colonoscopies. So before we used to have time interval surveillance recommendations of 1, 3, 5, and 10 years, but in the last few years we've seen the mortality data, and we've actually moved a little bit further away from the 5-year mark. So we are saying if it's a normal colonoscopy, they still have the 10-year standard follow-up, and but if they have 1 or 2 small adenomatous polyps, not sessile serrated, but adenomatous polyps, and they're less than 1 centimeter, they can go to 7 years for follow-up. So that's better, and the patients always like hearing that because 2 more years away from another prep or a colonoscopy. So that's always good. So that's just what I wanted to kind of point out. And the rest of it is still similar, where you're having the higher risk lesions like sessile serrated polyps further down with shorter surveillance intervals like 5 or 3 years, depending on how many and the size of them. If there's large polyps greater than 1 centimeter, we're bringing them back in a year. Okay, excuse me. All right, so just again, a little reminder for the multi-targeted stool DNA test. We talked about this. I see a lot of primary care doctors using the Cologuard tests for their patients. Again, it's great. It detects abnormal DNA and hemoglobin in stool. It's non-invasive, like we talked about, no sedation, and the patient can do it out of their comfort of their home. The downside is if it's positive, you're still requiring them to do a colonoscopy. And the cost can still be, cumulative. So if they pay for the Cologuard, which I think Medicare and Medicare are starting to cover, but again, then you have to come back for a colonoscopy, and now you're going into a diagnostic colonoscopy instead of a screening colonoscopy. So costs are different. So I think if you can have a discussion with your patient about positioning all of these tools, and with an informed discussion, find the right fit, that would be the best screening modality for that patient. Where we're going for future screening, there's research ongoing for non-invasive options like the stool studies and such, but so far we are not to the point where these studies do not lead to a invasive test like a colonoscopy, because if something is found, we still have to do that to detect what it is and to remove it potentially. So that still delays prevention. And there's new AI, artificial intelligence technology on the horizon that we're still working with that helps the operator, endoscopist, detect polyps that can be missed, especially these sessile polyps that are flat, and increase our yield during the colonoscopy. But it's still operator dependent, and you still have to remove the polyp at the end of the day. The AI is not doing that for us. But it does help with increased yield. So my final recommendations for our primary care doctors is that Colorectal cancer is a common cancer in the United States and in the world, and it's still the second cause of mortality in the United States. It's very much preventable, and we need to all work together to help in the factors that we can educate the patient on and improve mortality. So there's modifiable factors we talked about, where diet, physical activity, and insulin resistance, like obesity, that can be affected on early on. And we want to identify high-risk patients with symptoms away from patients who have no symptoms, so we can screen them early. And of course, the screening tools we talked about, the key is to find the tool that they'll adhere to and that they can then do in a timely manner so that it doesn't delay their detection. So colonoscopy is still the gold standard, as a reminder. And remember to start screening hereditary patients at an earlier age, and then if they are average risk, this is a typo, it should be 45, not 40, 45 years of age. Maybe down the road we'll get to 40. But key is to tailor the plan to the patient, talk to your colleagues, your gastroenterologists or colorectal surgeons, whoever are doing the screening for them, and have an informed discussion. And as a reminder, March is Colorectal Cancer Awareness Month, so we can all remind our patients about that. Thank you.
Thank you, Dr. Mather. We have time for a couple of questions, if you don't mind. We might just, depending on the length of the talks, we might answer the questions up front. One of the questions, can women get colorectal cancer, or why men get it more often? Why do men get colorectal cancer more often?
Well, we do know that it's actually fairly equal rates, but yes, there's slightly more in men than women. I have a few thoughts on that. I mean, I think sometimes it is also screening. So men tend to not come to the doctor. We know this for many diseases. So they're delayed in coming to the primary care doctor talking about their symptoms. There's a lot of cultural and gender-related phobias about somebody looking at the bottom, and doing a colonoscopy or a rectal exam on them. So I think from inherently as a gender, they tend to be hesitant in talking about their disease. So I think there's something about that. But it is improving. I think knowledge and communication about screening is improving. So we hope to, diminish that gap between men and women. Genetically, we don't fully understand why there are some more risk factors for men versus women, but I think we know diet and all these alcohol, tobacco, these kind of risk factors can also be more prevalent in men than women. But again, these are all starting to become similar risk factors in both genders, so the gap between the men and women is not that different. So I think there's a lot of risk factors that go along that make men delayed, in my opinion.
There's a few more questions. I think we'll get to these questions at the end. Our next speaker is Dr. Manisha Singh. She's a medical oncologist here at the Med Center. She's going to talk to us about genetic mutations and syndromes associated with colorectal cancer.
Thank you, Dr. Arrington, Dr. Espinola, for allowing me to participate in the symposium today. I am a medical oncologist. My name is Manisha Singh, and I will be talking to you about genetic syndromes that increase the risk for colorectal cancer. What I'll do is review what these syndromes are, and then we'll go over the impact on screening and follow-up, as well as impact on treatment, and then have a slide on terms of how we can test our patients. So what are the genetic syndromes that increase the risk for colorectal cancer? I've divided it into more common and less common. In general, colorectal syndromes have about a 10% incidence in terms of causing overall colon cancers. The more common are Lynch syndrome, familial adenomatous polyposis, MUT-Y human homolog associated polyposis, or MAP. And then the less common is on the right side, including Gardner syndrome, Cowden, and Li-Fraumeni. For the talk, I'll focus on the three more common ones. So who do we consider, or who is kind of like a red flag that we need to consider for genetic testing that we're seeing in our clinics? So certainly somebody who comes in saying that they have a family history of Lynch, we would certainly test that patient. If somebody has on their colonoscopy multiple polyps, defined as more than 10 adenomatous polyps, greater than 2 hamartomatous polyps, or greater than 5 serrated polyps prior to the sigmoid colon, those are patients that we would consider for testing. And if the patient has a personal or family history of Lynch syndrome-associated cancers. So what are the Lynch syndrome-associated tumors? Of course, colorectal being very common, but actually the next most common is endometrial cancer. In addition, Lynch syndrome increases the risk for other GI cancers, such as pancreatic cancer, biliary tract tumors, as well as small intestine tumors. It also increases the risk by about 5% of ovarian cancer, and also patients can present with ureteral or renal pelvis tumors as well. Also, if you have a patient, they've seen dermatology, they have a bunch of sebaceous adenomas or a sebaceous carcinoma or a bunch of keratoanthomas, those are patients also that have a red flag that should be considered for testing for Lynch syndrome. So what is Lynch syndrome? What's the mechanism behind it? It's basically a mutation in the genes that encode proteins that help repair DNA mismatch repair. So the germline mutations affect predominantly MLH1, MSH2, MSH6, or PMS2. This leads to dysfunctional proteins that can't repair DNA breaks that well. And if you can't repair DNA breaks, you have an increase in what we call these microsatellites. And so these patients tend to be microsatellite high. So one of the ways that we screen patients for Lynch syndrome who have colon cancer or endometrial cancer is on a molecular level. All of the patients now who have these cancers are tested on the tissue itself by immunohistochemistry for mismatch repair proteins, whether they're present or not present, as well as PCR for microsatellite instability. Now, just because the patient has a mismatch repair deficiency doesn't mean that they necessarily have germline Lynch syndrome. The patients who have mismatch repair deficiency on their tissues may also have it just because it's sporadic, meaning it arose in the patient's tissue itself. And so one way to kind of differentiate is by looking at something called promoter methylation. So I just want to pause for 1 second and go over the PATH report, which now when you are primary care, you'll see on all your colon cancer and endometrial cancer patients that there will be this thing about mismatch repair and MSI. So in patients that have a mismatch repair deficiency, meaning the immunohistochemistry is not picking up that protein on the tissue, they'll tend to have a deficiency, it'll say in MLH1, MSH2, MSH6, or PMS2. PMS2 is the most prevalent, but MLH1 and MSH2 have the highest association with colorectal cancer. So what we usually look at then, and the pathologists do this on the tissue reflexively, is we look at MLH1 promoter methylation. If the promoter methylation is present, then most likely this is sporadic and unlikely that your patient has a germline mutation. Also, they're likely sporadic if they have on their pathology report a BRAF V600E mutation. Now, these things are not 100% sensitive. If I have a 35-year-old who's MMR proficient, I'm still going to be doing germline testing on them. But this is just a quick way of screening patients for Lynch syndrome. Now, of course, for primary care, you may not be seeing necessarily a patient who has active cancer and you're looking at the PATH report. You'll be going potentially more by personal and family history. So what are the things that we look on terms of personal history? So certainly if somebody has a colon or endometrial cancer that is MMR deficient or MSI high, does not have the promoter methylation, those patients should be offered germline testing as it will impact their management and of course their family. If a patient comes in and has a known variant in the family, we would test them. If a patient comes in and they're young and they've been diagnosed with a Lynch syndrome associated tumor such as colon or endometrium, you would also want to consider testing them if they're young, less than 50. If your patient has had one Lynch syndrome associated cancer and yet another one as well, you certainly would want to consider testing for them. If they have a cancer and they have more than one first or second degree relative with a Lynch syndrome associated cancer age less than 50, those patients would qualify for testing. Or if they have cancer that's Lynch syndrome associated, that is a Lynch syndrome-like tumor, and they have more than two first or second degree relatives, even if they're above age 50, with Lynch syndrome associated cancer, you would want to test those people as well. Now, of course, we go also by family history. So if you're taking the family history and they have a first degree relative who has a colorectal cancer or endometrial cancer age less than 50, you would want to consider offer testing to the patient. If they have a first degree relative who has two Lynch syndrome associated cancers, they would also be considered for testing. If they have greater than or equal to two first or second degree relatives with Lynch syndrome associated cancer and one of those relatives was less than 50, that would also qualify for testing. Or if they have greater than or equal to three first or second degree relatives with Lynch syndrome associated cancers regardless of the age. What are the clinical features for Lynch syndrome? Tend to be younger patients who have these cancers. You tend to see right-sided lesions. They do have an increased risk for having presentation with cancers in 2 different parts of the colon, or metachronous, meaning developing cancer once and then a few years later, unfortunately, developing cancer again in the colon. They have extracolonic manifestations, as we discussed, increased risk for endometrial, et cetera. And then the lifetime risk of colorectal cancer in a Lynch syndrome patient who has a germline mutation can vary from low as 12% all the way up to 90%, depending on which gene is mutated and what's the penetration of the mutation. So let's move now to the second one, familial adenomatous polyposis, or FAP. This is autosomal dominant. Lynch syndrome also is autosomal dominant. This is a different mechanism. This is a germline mutation in the APC gene. The APC gene encodes the APC protein, which is a tumor suppressor protein. So you have 2 different subtypes. You have your classical FAP and your attenuated FAP. Classical FAP is your early onset of at least 100 cumulative adenomas in the large bowel. These patients will all develop colorectal cancer. They also have a increased risk for duodenal cancers, hepatoblastomas, thyroid, and gastric cancers. These are patients which we'll discuss are definitely going to be looked at for prophylactic colectomy or proctocolectomy. And of course, there's attenuated FAP. These are patients who are a little bit different. They have a later onset of disease, fewer cumulative adenomas, but still ranging from anywhere from 10 to 100. And they do also have a very high risk of developing colorectal cancer, so they have very frequent screening, which we'll talk about, and they do have a very significant rise in terms of their risk of developing colorectal cancer once they reach the age 40. And then the last one I want to talk about is a MUT-YH-associated polyposis. This is autosomal recessive. So this is a mutation in the MUT-YH gene, which encodes the DNA excision repair protein. So of course, if that's mutated, you're going to have more mutations. That's going to increase your risk for developing cancer. This also not only increases their risk for developing, lots of polyps that can develop into cancer, but also increases their risk for duodenal cancers. So these patients are also screened in addition to colonoscopy with upper endoscopy. Now, you may have patients who have biallelic mutations, and you may have patients who have monoallelic mutations. So biallelic means they had a mutation from both mom and dad. These are the patients who have a much higher risk of developing colorectal cancer. And then you may definitely run into patients who have a monoallelic mutation. About 1 in 50 individuals of European descent will have a monoallelic MUT-YH mutation. But their risk of developing colorectal cancer, again, this is an autosomal recessive, is only a modest increase, pretty much equivalent to for example, a normal individual who has 1 relative with colorectal cancer, so about a 5 to 7% lifetime risk. In terms of clinical presentation, they do usually develop quite a bit of polyps as well, but typically later in life, around 5th to 6th decade. As I said, they have an increased risk for developing other cancers that needs to be thought of. And then they can tend to have these extracolonic features that I've listed there as well, including osteomas and desmoids. So once we've made a diagnosis of a patient who has Lynch syndrome or FAP, what is the impact on screening and survivorship? So let's focus on Lynch syndrome because that's going to be our most common syndrome that's associated with colorectal cancer that you guys will see. So the colon cancer surveillance for a patient who has a germline mutation is certainly different than your patient who's just, without any mutation. So these patients, they actually start quite early. They start in their 20s, or at least 5 years younger than the youngest diagnosis in the family. And these patients have an accelerated risk of transforming from an adenoma to an actual invasive carcinoma. It can happen in a 1 to 3 year time frame. So that's why these individuals are recommended for screening colonoscopy on an every 1 to maximum 2 year basis. Other things to just be aware of in terms of when you have a patient who has Lynch syndrome, it's a female. They have the second most common Lynch-associated tumor is endometrial cancer. They have a lifetime risk of up to 60%. So these patients are educated to report any dysmenorrhea or postmenopausal bleeding. In terms of monitoring, it's sort of case-by-case discussion. Hysterectomy definitely is discussed with these patients after childbearing. And then you can also consider screening of the endometrium with biopsy and ultrasound. About a 5% incidence of ovarian cancer. And so again, symptom education, Bilateral salpingo-oophorectomy prophylactic can certainly be discussed with these patients, and then a transvaginal ultrasound CA-125 at your clinician's discretion. It's not as particular screening in terms of the gastric, duodenal, or distal small bowel, sort of based on patient symptoms, also their family history. Urinary tract cancers, I get at least a urinalysis. We could consider also urine cytology once a year. And then again, symptom education. If you have pink urine, definitely give me a call. Pancreas, again, no specific screening recommendations, but again, education in terms of pain. Now, if I have a patient who has a pancreatic cancer history in their family and they're a Lynch syndrome patient, I definitely will talk to them about MRI screening or endoscopic ultrasound screening. Breast cancer and prostate cancer, sort of standard screening, PSA yearly, mammogram yearly. Now, in terms of the FAP patients, these individuals will need to be followed by GI and colorectal or surgical oncology. They have very frequent and early screening, and because they have such a dramatic increase in incidence of colorectal cancer, as I said, basically 100%, they will be seen by GI and colorectal, and they will be counseled for prophylactic colectomy or proctocolectomy, potentially even as early as the second decade of life. In terms of MUT-YH-associated polyposis screening, again, if it's a biallelic, they got both bad genes, their surveillance colonoscopy will begin also very early in their mid-20s, and again, they are also repeated every 1 to 2 years. And we also, because of their increased risk for duodenal cancer, usually do upper endoscopy as well. And lastly, also remember to screen their thyroid with an ultrasound as well. And as I mentioned before, monoallelic variants, again, which you'll definitely run into, we pretty much just manage them as though they have a positive first-degree relative with colorectal cancer. So they would need to start at least at age 40 or 10 years earlier than their first family member who had cancer. And they are screened at a little bit tighter interval, not every 10 years, they're screened at every 5 years if they're monoallelic. So what is the impact in terms of on treatment? So treatment considerations in genetic syndromes that increase the risk for colorectal cancer include talking about chemo prevention, surgical management, what are the impact on our treatment decisions as oncologists for adjuvant chemotherapy, and also about immunotherapy. So let's talk a little bit about chemo prevention, which is certainly in the realm of primary care. So as Dr. Matur had already talked to us about, there is definitely evidence of aspirin reducing the risk or incidence of adenomas and potentially invasive cancers. So there's a large and compelling body of research that shows NSAIDs do inhibit colorectal carcinogenesis. NSAIDs have been found to induce apoptosis in invasive colon cells. So basically cyclooxygenase, which is of course inhibited by NSAIDs, is involved in colonic tumorigenesis. So I will talk about 2 chemoprevention trials. The first one is the CAP2 trial, and this was specifically in patients who have Lynch syndrome. The patients were randomized between 600 milligrams once a day of aspirin versus a placebo. So we had about 430 patients on each arm, and then they were followed up, and the patients had aspirin for a minimum of 2 years. And as you can see here, you don't really see much of a difference in terms of incidence of colorectal cancer in the beginning, but as they're followed out up to 10 years and beyond, that's when you start to really see the reduction in the incidence of invasive colorectal cancer, pretty much up to maybe a 60% reduction in invasive colorectal cancer. So certainly chemoprevention with aspirin doesn't necessarily have to be at this dose, can certainly be considered for your Lynch syndrome patients. I will also talk about a second trial for chemoprevention, which is using a NSAID celecoxib, second generation NSAID, and this was the APC trial, which is the adenoma prevention with celecoxib trial. So these are not patients who have an actual genetic syndrome, but these were individuals who were deemed a little bit higher risk. They had several adenomas, or if they had an adenoma greater than 5 millimeters, and they had randomization about 680 to placebo, 680 to 200 milligrams of Celebrex twice a day, or 400 milligrams of Celebrex twice a day. In terms of outcomes, as you can see, again, having Celebrex did reduce the incidence of all adenomas compared to placebo, as well as advanced adenomas. And again, the data showed that we see these differences after several years, up to towards 10 years after having taken the celecoxib. Now, the duration of the medication was up to 3 years. Now, this trial was stopped a little bit early in some of the patients just because of the cardiac risk. And certainly, Celebrex is a reasonable thing to use in chemoprevention, especially in patients who have genetic syndrome increasing their risk for colorectal cancer. But of course, if they have cardiac issues, you would probably want to stay more towards aspirin rather than Celebrex. What is the impact in terms of surgical management? So if a patient has a Lynch syndrome, they certainly have an increased risk of having metachronous colorectal cancer, meaning developing a cancer once and then down the line developing cancer again. So in individuals where the surgeons know or the treatment team knows that they have Lynch syndrome and they've been diagnosed with colon cancer, these individuals are counseled for total colectomy, potentially with the ileorectal anastomosis, or if they have a rectal cancer, a total proctocolectomy with ileal pouch anal anastomosis or a permanent ileostomy. So I gave an example here of a study of 382 carriers of Lynch syndrome, basically the mismatch repair gene mutation, and they underwent surgery for their colorectal cancer. So up front, about 50 of these patients chose extensive colectomy. And at follow-up, and this was after quite a bit of follow-up, over 10 years of follow-up, none of those 50 carriers developed an invasive carcinoma again. In patients who decided, for obvious reasons, they didn't want their whole colon out, they just wanted to have a segmental resection. After over 10 years, did see about 22% diagnosed with the metachronous colorectal cancer. So patients are definitely, based on data like this, counseled for prophylactic colectomy if they have Lynch syndrome and an invasive cancer. We don't do prophylactic colectomy if they don't have an invasive cancer, unlike APC patients, APC gene mutation patients. And then certainly patients like this who have a invasive cancer and they don't want to have a colectomy, these are definitely patients who we would want to think about chemoprevention. In terms of the surgical management of FAP patients, again, as mentioned before, these patients have a very high risk of developing colon cancer. So very early on, they are counseled for either a total proctocolectomy, a total colectomy with ileorectal anastomosis, or a total proctocolectomy with a permanent end ileostomy. In terms of MAP patients, they do not have upfront total colectomy if they don't have invasive cancer. Patients who have suspected colorectal cancer, or if they have a huge burden of polyps that cannot be effectively managed with colonoscopy, that's when potentially total colectomy could be considered. But basically the various options can be discussed with them, partial, subtotal, or total, depending on their clinical situation. What is the impact of Lynch syndrome for us from a medical oncology perspective? So it does have an impact in terms of when we are seeing a patient who has invasive colon cancer and is a Lynch syndrome patient. Interestingly, these patients have a little bit better outcomes that have the mismatch repair deficiency and microsatellite instability. And studies have shown that they actually may not benefit as much as those who are MMR proficient from adjuvant 5-fluorouracil. So for example, if we're seeing a stage 2 colon cancer patient where there is some controversy whether those patients benefit or not benefit, usually we will lean against doing adjuvant chemotherapy if they are MSI high or MMR deficient. And then in terms of the impact of immunotherapy, when we are seeing patients from an oncology side with mismatch repair deficiency, this does have a huge impact in terms of potential therapeutic options in individuals who have stage 4 disease. So I put here a study here which looked at what was the responses with patients who had advanced colorectal cancer to immunotherapy that were mismatch repair proficient, meaning no Lynch syndrome, or those patients who had Lynch syndrome or had a mismatch repair deficiency in their cancer tissue. And as you can see in the red, you didn't have any response to immunotherapy, basically. But if you have a mismatch repair deficiency, microsatellite high, Lynch syndrome patient, they can have a really fantastic response to immunotherapy. We've seen even sometimes complete responses in these stage 4 patients. In terms of testing, how do I test my patient? There's different options for you guys. Certainly, it's gotten a lot easier to just test through a commercial lab. Now, basically, you just have to click colorectal panel. You don't have to click individual, I want to check MMR, I want to check APC, because this tests have become really inexpensive these days. And so you could certainly test your patient in the clinic through Invitae, Myriad, Ambry. And also a nice advantage that these companies have is they do offer genetic counseling, virtual genetic counseling, free for cost for the patient. And these are with genetic counselors who are licensed here in the state of Texas. There aren't a million physical genetic counselors everywhere, so this is a kind of a nice thing to just be aware about. You can certainly also refer to medical oncology. Obviously, because we are seeing patients with ovarian or colon cancer, we've become quite used to doing genetic testing on our patients. And so if you feel more comfortable to send to oncology for testing, that would be totally fine as well. And these are the ways that you could potentially refer through our oncology nurse navigators, or simply call your local medical oncologist to get this done. Here at the Med Center, a lot of times we'll see concurrently with a genetic counselor in the clinic, and we have ability to refer to her as well if we see a positive test, and for example, we had tested the patient on our own. So these are my references here, and I'm happy to take any questions.
Thank you, Dr. Singh. Dr. Singh needs to leave a little bit early, so I'm just going to go over the questions that came through the chat. One of the questions is a little long, so I'll read it. What is the frequency of mutations in the Lynch-associated cancers in the general population? As an MFM, we often acquire from pregnant women and often their partners genetic screening in their first or subsequent pregnancy. Is that part of the genetic screening? And if not, how expensive would it be, or how complex would it be to add those on?
So for pregnancy, the genetic screen does not include Lynch mutations. The frequency of mutations in general population is about 3%. So I don't think this is standard for the genetic screening in pregnant ladies. But the test, if you want to do it, would become very cheap. Cash pay Invitae for a full panel testing, if you want to check 84 gene panel, is about $200 to $250.
I think you actually answered the other couple questions. How expensive, and is it covered by insurance? So
yeah, most of these tests are covered by insurance. Again, it's easy to pay cash these days. You know, it used to be when this started, it was thousands of dollars. It's difficult to get insurance coverage. But now I usually don't get a pushback from insurance if you have a rationale. And again, even if it's a underinsured or uninsured patient, it's pretty easy to pay. Also, Myriad has programs to pay, so you can apply for that for your patient as well. The other thing that sometimes comes up as well is what's the risk to my patient for testing, genetic testing? So what I try to reassure the patient is, one, there was a law passed by Congress, I think it's more like 15 years ago now, that makes it illegal to discriminate against individuals based on their genetic testing. And then second, with the Affordable Care Act, gone out the window is this issue of pre-existing conditions. So, you should reassure your patients in terms of that. And then the other thing also to touch on is, of course, if you find a genetic syndrome, you certainly want to start testing all of their first-degree relatives. And that's where you may want to start. That's where genetic counselor is very good, because they sit down with the patient, because this is very anxiety-provoking. Okay, I'm going to have to tell my family that I have this thing that increases my risk for cancer. So that's where a genetic counselor is very useful. They'll tell the patient how to do that, how to approach. They'll write letters for them. And this service, again, can be in person, or it's very nicely done also now virtually for free with these companies as well. Thank you very much.
The one benefit of COVID, all the virtual visits and the ability to see people virtually. Our next talk I'm actually going to present. It's surgery for localized colon cancer. I talk rather fast, so we'll get through this in the allotted time. So why is this important? Why do you, primary care, as primary care, you need to know about the surgery, anatomy and surgical options, and we'll briefly discuss the minimally invasive progression of surgery. When we talk about typical colorectal cancer sites, where the patient develops a cancer and what kind of symptoms they may present to your office can be completely different. In general, most of our colon cancers, I don't know if I can do this, and I hope you can see this, 20% of colon cancers present in a sigmoid colon, and that's why colonoscopies, sigmoidoscopies were favored for a while and has come out of favor for the full standard colonoscopy. Descending colon cancers. So most of our colon cancers in the population is going to be in the left side of the colon, and that's, again, where you're going to see symptoms. The biggest symptom for all colorectal cancer is most patients come in asymptomatic, and that's why we need to screen for and do screening colonoscopies for our patients. When they do have symptoms, it's really based on where the cancer is. Right-sided colon cancers, sometimes you'll see pain. You might be able to feel a mass in the right lower quadrant, and 50% of patients that have symptoms may have weight loss. In the rectum, we might see a different set of symptoms. It's more of an obstructing type of tumor. When we ask patients, a lot of times they'll talk about changing caliber of their stool, intermittent constipation or diarrhea, kind of, and the amount of stool they're actually having at a time. They can have incontinence or pain depending on how far it is from the anus itself. Anatomy really matters where a colon cancer is, and it's really based on the blood supply, what surgery we will recommend when we see a localized colon cancer. So blood supply really dictates where our lymph node basin will be. So if we have a right-sided colon cancer, we're taking out the ileocolic chain, so all the right-sided part of the colon cancer, colon up to the transverse colon. And accordingly, if you had a transverse colon cancer, it's a different segment of colon we're going to remove. Why does this matter? First of all of our surgical options, we have the same goal. Our goal is to remove the cancer, get an adequate lymph node evaluation, and ligate the feeding vessel. So whether it's an open colon surgery that we did prior to the in-vena laparoscopy back in the 80s, whether it's a minimally invasive laparoscopic colectomy or a robotic-assisted colectomy, the goal of the surgery, the goal of the oncologic resection is the same. And again, it really depends on where the colon, where the cancer is, which surgery we recommend. Why is this important for you? And what do we tell our patients for their long-term side effects? It really changes what kind of expectations we can give our patients. So if your patient has, let's say, one bowel movement a day prior to surgery, this is kind of what I tell my patients they can expect long-term after surgery. Now, this is not a gold standard at all, but it gives them an expectation. You have minimal changes on your right colon, and when we go back to our anatomy of the colon, all the colon really does is absorb water. So our stool comes into the right colon and is liquid in consistency in the right colon. Most of the colon water absorption is on the left side of the colon. So as you see, the more of the left side of the colon we remove, the potential for more bowel movements or a change in bowel movements. There's going to be less formed or smaller in caliber, or smaller in amount, not caliber. So depending on what we have to recommend, which part of the colon depends on what your patients will have long term and the expectations. Again, the entire goal of all surgeries, including the minimally invasive techniques, which we all employ now, is equivalent or improved outcomes compared to open surgery, equivalent or improved oncologic outcomes, and an avoidance of excess cost. So why not do minimally invasive surgery? Well, our first laparoscopic GI surgery was in 1981 with a laparoscopic appendectomy, and we've moved miles from that. And we've progressed to robotic surgery and laparoscopic surgery for many, many cases in different disease entities. In the beginning, there was a huge operator debate on whether or not we should even adopt laparoscopy, and now we're having that with robot. And I think Dr. Haas might talk about that in our next talk. You can have all kinds of different barriers to adopt these, but it's kind of like if you were a skier, and I'm not a skier, but I wouldn't take a black diamond slope before starting on the bunny slopes. So with laparoscopy and with robotic surgery, it's been a gradual adoption of all these techniques to where it's a universal recommendation for patients now. Evidence to support the transition of to laparoscopic surgery and minimally invasive surgery. We see, compared to open surgery, shorter lengths of stay, fewer complications, less blood loss, less narcotic pain use, and more of a multimodal pain regimen, quicker return of bowel function, and quicker return to normal activities, and honestly, better cosmesis. You don't have a big, long midline incision. You've got smaller incisions. The reported incidence of port site metastasis is negligible now. It's less than 0.1% in most all colon cancers. So multiple studies have shown that laparoscopic and minimally invasive surgery is equivalent to open surgery. And this is kind of the difference in the incision. This is on the right, you can see kind of a lower midline incision just above the belly button all the way down to the pelvis. That may have been for a right hemicolectomy. And on the left, you can barely see the port sites for a similar surgery. So cosmesis is certainly different when comparing open and laparoscopic surgery. Cost effectiveness. Initially, when laparoscopy started, the costs were higher. We had longer operating times because you had a plateau. You had to get over the learning plateau. Capital and recurring costs were higher. These have all been mitigated in laparoscopic surgery in the past 40 years, and we're coming down on even the cost with robotic surgery. The higher costs have been offset, particularly in the laparoscopic world, because patients are in the hospital less. There's fewer complications, fewer wound infections, and we're able to get them off of narcotics sooner. So overall cost to society now is comparable between open and minimally invasive surgery. This is just one of the many studies, and you can tell, I can also age myself. 2004 is almost 20 years ago, but the COST trial just proved that the minimally invasive technique compared to open surgery, so the big incision, there was a shorter length of stay, even though it was only 1 day. It still is 1 day less in the hospital in overall hospital cost. Reduced use of narcotics for our patients. Nowadays, this is almost 0 days because we all go to a multimodal pain regimen that is non-narcotic, and long-term outcomes were similar and non-significant between recurrence, overall survival, and disease-free survivals. This was one of the first studies that showed that laparoscopic approach was acceptable to open surgery, and really provided the mainstay of pushing technology and pushing minimally invasive surgery even more forward. Some of the cost comes from all of our disposable equipment. Time in the operating room. When I studied this at a previous institution, it was about $43 a minute. So if we're able to decrease that time with getting over our learning plateau or a minimally invasive surgery, that will also decrease overall cost. Some of the energy devices really have helped push laparoscopic surgery. We actually use these energy devices now in open surgery, so the cost of that will be comparable because we're using it in both techniques. The only real difference in cost will, nowadays, honestly, is going to be the access device. So whatever trocars and disposable ports that we use, that would be a small additional cost, but everything else is pretty much the same between open and minimally invasive surgery of the instruments that we use. So preoperative considerations when I see a patient that comes in with a colon cancer. Number one, is it localized? Have they been completely staged? And where the cancer is. Minimally invasive, right and sigmoid colon has been shown to be easier. They're more floppy. They have less tension on them. So overall, the surgery on those two sites, the surgery times are less. How big this tumor is, and is there invasion of any associated tissue around it. If we have a larger cancer that's invading the soft tissue or invades like the omentum that's surrounding it, sometimes those cancers are just safer to address with an open procedure. So, there are cases that I do recommend a big midline incision. Obesity, the larger the patients are, sometimes the harder it is actually to do an open procedure, and the easier it is to do a robotic procedure. So it really, the size of the patient and what their abdomen looks like really matters what we'll recommend surgically. If they've had previous surgery and we know they have scar tissue, sometimes it's easier to recommend an open surgery and safer. And if we're trying to put ports in and there's a lot of scar tissue, we may talk to the patient about the conversion to open. And in every case, whether we're doing a robotic surgery, a laparoscopic surgery, even a pure or a hand-assisted laparoscopy, I do talk to my patient about the need to convert to open and the conversion rates. Our conversion rates to open have significantly decreased over time, but it's still there and it's still a possibility. And if it's the safe thing to do for their patients, we do it. And probably the most important on this slide, we have to be able to find the polyp or find the cancer. So if we're doing these, if we do offer a patient a laparoscopic case, we're going back to our colonoscopy that our gastroenterologist did, and to see if they've actually tattooed the lesion. A tattoo means a lot and aids us in surgery. What your patients may see and what you might see on the colonoscopy, however, may be very scary. You may see this black lesion on the colonoscopy report. I've had multiple patients come in to me and say, well, what is this? Why is it black? This is badness. And I have to explain that this is that tattoo, and it helps guide our surgery and helps us remain laparoscopic. So you can see this is probably only 0.2 cc's of a blue Indian ink. But because we don't have the tactile ability to touch the colon with our hand to feel the tumor, this is our visual prompt of what we're actually operating on. What does this look like in the operating room? Well, these are laparoscopic images. You can see the tattoo on the outside of the colon. And this, again, gives us our visual prompt so that we know exactly which part of the colon we can see, we need to operate on. That whole tattoo area has to be within the resection margin, or within the resection itself. Laparoscopy has gone a long way. We can do a purely laparoscopic surgery, or if need be, or the colon has to come out of somewhere. Your patient's going to have some sort of incision. We can use that incision with an aid with a hand assist in certain situations to get that tactile feel and aid in surgery. It may be used up front as someone is getting over that learning curve. It might be because it's a bulkier tumor or the omentum is bulky and we can't get it off of the colon with our trocar or with our graspers safely. Outcomes have been similar to laparoscopy. Operative times somewhat shorter. The issue with this is you might not have as much visualization as open, so if you're using this to kind of bridge to an open procedure, it might be safer for the patient for us to just open, and a lot of us will. Robotic-assisted surgery, I'm sure Dr. Haas will talk about next in our rectal cancer talk. Robotic-assisted surgery has really expanded in the last few years. It is expected to surpass a $7 billion industry by 2025. It is used in a number of different subspecialty surgeries for a number of different disease entities. And why is this? Well, it really aids in visualization, and it gives you an extra degree of movement so that we can work in more narrow spaces in surgery. So what does it take for robotic surgery, and why is it really publicized and advertised and patients come in asking for robotic surgery? Well, of course, the smaller scar cosmesis is always beneficial. There are shorter hospital times in general. There are lower risk for adverse side effects, so lower bleeding risk. We can see very fine anatomy, such as nerves within the pelvis, to decrease the risk of erectile dysfunction, faster overall recovery times, and overall less pain. What does it take to do robotic surgery? Robotic surgery training is still in development in residencies. Most institutions have a plan that's somewhat similar to this. Fellowships certainly have a program similar to this. All of the training programs include some simulation, dry lab with basic exercises, working at our fine motor skills, a wet lab, sometimes that's animal-based, and then training with a mentor and progression of responsibilities in the operating room until you're fully credentialed. Potential benefits, again, I just went over this, and I'm sure Dr. Haas will go over it in a second. This was marketed, this is how my intuitive reps would market it when robotic surgery was really on the forefront. Faster recovery time, smaller incisions, reduced blood loss, minimal scarring, shorter hospitalizations again. The benefits for us, we do have much better visualization. We have enhanced dexterity. So in laparoscopic surgery, we only have 2 degrees of movement with our graspers. In robot, you have 4 degrees, so we have a wrist motion, so we can get in narrow spaces, particularly important in rectal cancers. Disadvantages, it has increased time because you do have to dock and undock the robot. Cost has been an issue. Every robot is $1 million investment, and some of the disposables and like the stapler systems have had high costs. They are coming down with time and with use with all the robots. And it does take extra training. I wanted to briefly go over colorectal surgery in the elderly patient, and is it safe? Anytime you have an elderly patient, we all wonder, what is the risk of surgery versus a benefit, and should we talk to to our patients? I absolutely do. There are very screening mechanisms and tools that we can provide, we do on our patients to assess their nutrition, their cognition, their functional status, and what surgery would do to alter these. One of the ones that I used in my previous institution was PACE. It began as an investigation aimed at defining the perioperative risk factors We had a geriatric oncologist that we work closely with, and with the geriatric oncologist and myself determined whether it was safe for the patient to undergo treatment. So it's all a patient-by-patient determination, particularly in the octogenarians. Multiple studies have shown that the operative mortality is determined by the same two risk factors regardless of age, pre-existing conditions, and the need for emergent surgery. In patients over the age of 80, elective operative mortality is about 2 to 3%, so it's not significant, but it is a consideration that we discuss with all of our patients. Treatment decisions have been shown, for better or worse, to correlate with chronologic age. This is one study, probably 15 years ago now, of primary care physicians in France that showed that chronologic age was highly associated with the decision not to refer patients with advanced cancer to the oncologist or to the cancer centers. You know, what you could take out of this is, even if a patient has an advanced chronologic age, refer the patient to the oncologist, to the surgical oncologist, just to discuss the risk benefits of treatment options and what would be best in that patient and his or her family to make an informed decision. We do have risk calculators that we can provide and we can use on our patients to actually quantify the chance of a morbidity or mortality based on their actual underlying coexisting diseases. This is one that most of us use, the American College of Surgeons website, the risk calculator out of that. I just briefly run this so that you could see what it could look like. This was an 80-year-old female with diabetes, hypertension, and overweight but not obese for a left colectomy. And we could actually provide a PDF of this for our patients to show that they have an above average risk compared to the average risk in their particular disease age group of a complication of a surgical site infection. The return to the OR is going to be about the same in these patients. So after providing this to the patient and their family to discuss the risk and benefits of surgery, and they can make it as best of an informed decision as they can for their particular case. So long story short, there's many ways to skin a cat, for lack of better terms. We have converted what we've done open for many, many years to minimally invasive. We've found new toys like the robot to provide options for our patients, and it actually benefits the surgeon as well. It all is about training and absolutely sending all of these patients to a multidisciplinary team to determine the right treatment plan, because no one particular option is best for one patient. So providing them with as many options as they need and to determine the right treatment plan is absolutely essential. So I appreciate the time. All right. I think, let me see if there's any questions here. One of the questions that came in is, as far as benefits versus risk, do you recommend narcotics post-op? Each surgeon has a different plan of care. What's the best option for pain control? We are, for multiple different surgeries that we offer, we're trying to not recommend narcotics for post-op care. We do have a multimodal pain regimen, and I think many surgeons are kind of transitioning that way. For my open surgeries, some of my patients get an epidural. They do have tap blocks, so a local anesthetic along the rectus sheath that all of my patients are offered. And then there's a multimodal regimen of gabapentin, Celebrex, tramadol, Robaxin, so that we can really minimize narcotic use. Across the country, this is a trend that most surgeons are picking up. My other surgical colleagues that are giving talks can certainly answer what they recommend for their patients. All right. So our next speaker is Dr. Eric Haas. He is a colorectal surgeon that's been in Houston for many years, and he's going to talk about the surgical options for rectal cancer. Section is like a 10-minute break. So we're going to go ahead and do that 10-minute break now, and then we'll come back at 9:45 for Dr. Haas's talk. Thanks. over our technical issues. So Dr. Haas is going to present surgery for rectal cancer.
Okay. There we go. Okay, so I want to begin by just introducing our team over here, and as what's already been talked about this morning, those in the room and those who are going to be giving talks today, it's a team approach to tackle colorectal cancer, and very much dependent on how we work among ourselves. So we're going to go through some of these objectives in just 30 minutes, and bear with me, because when you talk about rectal cancer, symposiums like this could be an all-day affair. So we're going to put it into 30 minutes and just touch on some of the key aspects of evaluation and treatment options, and maybe some of the newer innovative approaches we have for rectal cancer. So what is the most common chief complaint that we see? The most common chief complaint, hemorrhoids, okay? So take-home message is that over 50% of patients who tell their primary care physician that they have hemorrhoids have something other than hemorrhoids. And we see it all the time. And I was going to say maybe there are 3 key messages to take home today. One of them would be, I personally would not treat hemorrhoids unless I knew they were hemorrhoids. So if someone has pain, bleeding, they feel a lump, you know, it's just hemorrhoids, take the cream and call me later. I would get them to your GI friends, I'd get them to your surgical colleagues. I would, you know, really want to do an exam in the office, and even in the young age of 20 or 30 or 40, because we're seeing rectal cancers in these ages. What's the most common symptom of rectal cancer? Bleeding. It could be bleeding when they wipe with a tissue paper, it could be bright red blood. But again, a lot of patients will say, oh, it's nothing, it's a little bit after a bowel movement. But sometimes it's something. Most common time of presentation, do they come a week after, 2 weeks after symptoms, months after symptoms? For rectal cancer, it can be devastating. You can find a huge mass in their rectum, and they're shaking their head saying, I started having this 2 years ago. I should have gone to my doctor, I ignored my symptoms. And these are the things we see each and every day when we take care of patients with rectal cancer. The most common age of rectal cancer, 70, 80, 90, under age 65. The majority of patients with rectal cancer, if you look here, are under age 65, even in their 40s, 50s, 30s. So everyone needs to be on alert. Other symptoms, change in bowel habits, they usually won't come to the office and say, I have a change in my bowel habits. You usually, we kind of draw it out of them. What are your bowel movements like? Are they thin in caliber? Are they more difficult to evacuate? And 45% of patients will have some sort of complaints of change in bowel habits. Abdominal pain is not so common. And then, of course, weight loss, fatigue, all of those warning signs of any sort of cancer or anemia. When it comes to these sort of symptoms, we're behind the 8 ball. Pelvic and rectal pain, rectal cancer can be just devastating in its later stages. Pain radiating down their leg, unrelenting, sitting on a rock, urgency, spasm. When a patient is sent to us for rectal cancer and they have these sort of symptoms, we know it's bad. We know it's very, very bad. And even worse is when we get a consult for obstruction, perforation. And I'm going to tell you, the COVID syndrome that we're seeing all over the country, patients are absolutely showing up later in their stages for colorectal cancer. They're avoiding screening. Even if they're starting to get back into the healthcare and taking care of their bodies and seeing their doctors, there has been a big delay for probably a year and a half. Yesterday, I was on a conference call with our colleagues in Mayo Clinic. It's universal. They're seeing, just like what we're seeing in Houston, patients presenting way down the line for colorectal cancer. So symposiums like this, talks like this, is kind of bringing back awareness that really any symptom of hemorrhoids, bleeding, I would take them all very seriously, because even if it's 1 out of 100, we're definitely saving lives with early detection. So what's the patient experience like for rectal cancer? I mean, it's a very common thing. Dr. Mather talked about colonoscopies. They get a colonoscopy, they're kind of, hazy, cloudy, kind of waking up, and we go to the bedside and say, hey, unfortunately, we found a mass. They get a report like this. There's an ulcerated mass. They're looking at this, and we're like, look, just wait for the biopsies, try not to worry. But then the patients get home and they're worried because they have a report saying they have a mass. This is what it's like for the patient. The colonoscopy reports might say we're going to get a CBC, we're going to get a CMP, we're going to get a CEA, a CT scan, colectomy, and pictures are given to the patients. This is this ugly looking thing here, ugly looking thing there. Go to Dr. Haas in Houston. The patients are absolutely dazed. And you might get a call from your patient saying, I got my colonoscopy, you sent me for a colonoscopy. What in the world is going on? Because a lot of times colorectal cancer has no symptoms at all. And so the patients are just going for screening, and then they show up a week later, we review the pathology report with them, or they get a call, they go to MyChart, whatever it might be, and they see these ugly words, invasive, moderately differentiated adenocarcinoma. These are our patients. They have no idea except they're in shock. And when they come to us, they are in shock. Because when they are told or they hear that they have rectal cancer, this is what they think of. They go on the internet, they Google, and they see colostomies, they see huge incisions. They're in shock. And many of you see this in your patients. We certainly do. Very confused. Things happen very, very fast. And they show up and they have two questions universally when they see me. Two questions. It's not, am I going to live? Question number one, am I going to have a colostomy? I have rectal cancer. Okay. No, most likely you're not going to have a colostomy. Dr. Arrington was talking about earlier, we have advanced techniques. We are avoiding colostomies in a lot of patients that we used to. But their second question is, when I say, no, you're not going to have a colostomy, their second question is, are you sure? Am I going to have a colostomy? It's a huge thing, and it's, for many of our patients, it's more than, am I going to live or am I going to die? It's quality of life. And something about rectal cancer and going on the internet and things like that, patients are very focused on their quality of life. They might know people, they might have heard of things, and I can appreciate that because it's a different ballgame when you have cancer way down in your rectum. Cure for rectal cancer, if a patient is curative, almost always requires a surgery at some point. But there's a lot of management options. It's very confusing out there. There's advances in oncology, multimodal therapy, new techniques, refinements in surgery. These are NCCN guidelines. We live and die by these guidelines. But this is not something that a patient is going to, we don't say go look up the guidelines. This is just one page out of numerous pages. Guidelines, guidelines, guidelines. This is why it takes days to go over rectal cancer academically, because each one of these guidelines has subheadings and subheadings. So we need to kind of figure it in a big picture. What can we figure out about rectal cancer? So staging is where it begins. We're not going to go into the details of staging, but the extent, a lot of patients say, how big? What's the size? Is it a golf ball? Is it a walnut? What's the size? It's really the depth that matters in colorectal cancer. How far this tumor, it could be a small little ulcer the size of a dime, but if it's going deep into the wall, it's going to be problems, because as it goes deeper into the wall, that's where the lymph nodes are, and so it starts spreading. So the early stages, it's just kind of superficial, going into just a little bit of the muscle, but then as we get to stage 2 and further stages, the cancer goes all the way through, so now the possibility of going to the lymph nodes and then disseminating and spreading is much higher. Stage 3 is probably the most common presentation that we get for rectal cancer. And that means, regardless of the size, it's already in the lymph nodes. And so that changes the approach once you know the cancer is already in the lymph nodes. Stage 4, we have metastatic disease. And there's still wonderful, wonderful treatments and cures, or at least long-term survival with metastatic disease. But obviously, we want to catch the cancers early. So I'm just going to show a few slides about, as surgeons, what we deal with when it comes to rectal cancer and why this needs to be differentiated today between colon and rectum. Because the rectum, well, I'll start here. There's 5 feet of colon in the human body, 5 feet. It spans a lot. But the rectum is a mere 15 centimeters. It's just the last few inches of these 5 feet control basically a tremendous amount of a patient's quality of life. This is where the stool is stored. This is where the body differentiates between gas and a bowel movement. This is where you hold your activities. This controls your life for many activities of daily living. It's these last 15 centimeters, that's not a whole lot. And within these 15 centimeters, we have a lot of critical structures. In the male, there's the prostate, the bladder. These are just millimeters apart over here. This is the sacral bone down here. Female, there's the uterus, the vagina, ovaries are here, millimeters apart down in the area of the vagina and the sacral bone. We have a very tight spot to address. This is another view of the rectum. This is the anal region, the sphincter muscles, the control, where we control bowel activity. Just 15 centimeters, that's all we have to work with. And when you have a tumor, remember the wall of the rectum, it's very, very thin. It's just a few millimeters, so it's very common for the tumor to already be T3. It's growing into the wall, and we only literally have a few millimeters to resect this tumor very low in the human body and get negative margins and ensure it does not grow again. So this is why rectal cancer is so intense. Also, there's just tremendous amount of nerves down in the pelvis, controlling bladder function, sexual function, pain, and all sorts of things. There's all confined to this space. So when a patient is diagnosed with rectal cancer, what do? Well, we start with the physical exam like pretty much every medical situation. So physical examination, we're looking to see if it's spread. We want to know, is this local or is it spread? And if it's just local disease, that's a great thing. So we do a physical exam, we're going to do labs, we're going to do imaging, we're going to do a staging workup. Now the colorectal exam is extremely important. Unlike colon cancer, the physical exam, you really can't usually feel it or tell where it is. The rectal exam, we're getting to it, you can very often in the office identify a whole wealth of information about the cancer. You can feel it often. The finger should go up into the mid-rectum. So almost half of the rectum you can evaluate with your finger. You're going to tell the size, is it fixed? I mean, there's all sorts of things. It's so important for the surgeons to get an examination of the tumor before treatment is initiated. So sometimes chemotherapy is given, radiation is given, but as surgeons, we want to see the patient first. We want to be the first ones to assess that patient and start mapping out the future care of that patient. So this is just an example of a proctoscopy. We do this in the office typically, but this is us literally measuring the distance of that tumor from the anal verge. On a colonoscopy, our GI friends, that's a wiggly tube, so something might look at 15 centimeters or 18, but we have to see an exact, rigid, straight measurement, and that kind of creates the entire treatment plan. So it's very important. We do this local staging. MRIs are essential for stagings as well. But if I want to say one thing, is that the MRI staging protocol is very different from an MRI of the pelvis. And for instance, at Methodist, the radiology department has just done a phenomenal job of these MRI rectal cancer staging protocols. One sort of frustration patients have is a lot of times they will get an MRI of the pelvis, just MRI pelvis, they get sent to us, but we have to do it again, and because we really need to use a cancer staging protocol that's very unique. The way they do it here is absolutely phenomenal, but often the insurance won't cover another one and stuff like that. So again, better to get the patient to the surgeon, we'll get them all packaged, we'll get those scans that they need. But then we have to put it all together. We've done the physical exam, the colonoscopy, the pathology, so many things going on. The stage we have to figure out. What are the characteristics of the disease? Where is it from the anal verge? The function, comorbidities of the patient, functional status. So much going on. How do we put all of this together? This is how we do it. Our colorectal tumor board. It's one of, again, an amazing features of this institution because every week we get together, my colleagues, many are in the room and giving these talks today, and we discuss each and every patient. We want to know everything about the patient before we make a decision. And what's very unique about our tumor board is everyone's involved. The pathologist, the radiologist, the colorectal surgeon, the gastroenterologist, the oncologist, the radiation oncologist, and it's more than just one surgeon, it's a colleague of surgeons. So we have consensus opinions, we kick it around, we look at every aspect of the patient care. And I think that is crucial and critical for rectal cancer patients. And we're very lucky and fortunate to be able to have those resources here. Because look at the options. I mean, these are the options on one patient, on one cancer. And it's just unreal how many options there are. So when we're able to sit down with our colleagues and vet out each and every patient, and what's interesting is we see the patient, we try to calm their nerves, they come in with shock, we assess them, we get all the options, and then we say, listen, we're gonna present you at our multidisciplinary tumor board, and then afterwards we're gonna meet back with you and tell you the plan of care. I mean, they feel very calm about that. They know there's a lot of people looking after their care. So let's get now and finish this talk with what do we do? And I'm not going to get too specific, but I'm going to break down the patients into early cancer. We're very fortunate if we find patients early where the cancer is T1, meaning it really hasn't even gotten into the wall. It's just superficial. Only maybe 10% of our patients present like this, unfortunately. But what we do here is very fortunate. We're able to just excise it through the rectum. They can avoid the big surgeries. And again, it's a small patient population, but this is the advantage of finding the cancers early. When it's early, we can actually go in. They don't even stay overnight in the hospital. They heal pretty much without any side effects, and it's amazing. Unfortunately, it's not so common. What happens, though, if it's an early small cancer, but it's too high in the rectum for us to go in directly? So then we go in with this technique called video assisted. We actually put a laparoscopic camera through the rectum, and we're able to blow in air like a colonoscopy, but the air doesn't evacuate. And under a camera and using longer instruments, because we couldn't otherwise reach it, we're able to go in and visualize in beautiful visualization. We outline the tumor there. We want to get 1 centimeter margins, and we're able to get full thickness resections. That's a big crater left in there after we take it out, and then very slowly, meticulously close up this defect. This is called a video-assisted transanal excision. People call it TAMIS, but the take-home message is when it's early, either under direct vision or going in with these laparoscopic instruments, it's a pretty innocuous procedure considering somebody has rectal cancer. But that's the minority of patients. This is a T2 lesion. It's going into the bowel wall, but not yet having lymph nodes. This is also a smaller patient population, maybe 20%. What's good here is that you can go straight to surgery and you don't have to pre-treat the patients with chemotherapy or radiation. It's T2, there's no lymph nodes involved. The surgery is called a low anterior resection. That's the name of it. So LAR, low anterior resection, that's what we call the surgery. Taking out the rectal cancer. You do have to go through the abdomen. You have to remove a portion of the colon. A lot of patients say, how much colon are you going to remove? They're very infatuated with how much. I say we have to go so many inches above and so many inches below. I tell you, if you tell a patient you're removing this much, all they focus on, I can't believe you're removing that much. I can't believe. So we go above and below. We have to get margins. But the reason we do have to remove as much as we have to remove is because we need to chase down these lymph nodes, okay? We saw the slide before. 12 lymph nodes is minimum. But the lymph nodes live on the feeding blood vessels. So to get all the lymph nodes in the cancer, you have to take that blood vessel pretty high. And then once you take it high, you have to remove the colon that blood vessel feeds, so you have good, fresh edges to sew together. But believe me, I tell patients you've got many feet of colon left. Let's just get the cancer out. So that's a low anterior resection. Okay, what happens when we're starting to get lymph nodes involved? When it's T3, when the lymph nodes are involved, this is really when we get together with our colleagues. We're going to need help. This is not just a surgical situation at this point. We're going to need the patients to undergo either chemotherapy, radiation, a combination. They need something because we need to shrink it. For many reasons, we need to shrink it, and that shows much better local control and a much better surgical outcome, reducing the risk of a colostomy, for instance. So that's another reason why we get together with our colleagues. But when they have locally advanced disease, this is the majority of our patients by far, for surgery, have what we call locally advanced disease. And that's when we get together and we pre-treat. I'm going to finish, as promised by Dr. Arrington, talking about a little bit about robotic surgery, because when you operate in these deep confined spaces of the colon and the rectum, robotic surgery really, really helps. So this is just an animation of what it is. We show this to our patients so they can get an understanding. It's a robotic device docked to them. The surgeon is actually sitting at a console away from the patient, but in the same room, so you have to have your assistants at the bedside. And by using computerized generated equipment and tools, you're able to operate and manipulate the surgery. So these are ports that we dock, that we put on the abdomen. This is the robot that we dock to the patient's abdomen. And we're seeing the timer over there. It takes about 10 minutes or 15 minutes to get the case going. And then you can see we're sitting at the console operating while we're looking in the abdomen over there. So it's a very, very interesting and unique way to do surgery. But this is, by and large, the majority of the rectal cancers are done that way. Basically, prostate surgery, that's where really this was popularized, very similar, very narrow area of the body in a male pelvis, which is narrow. And then we kind of started gravitating to what the urologists were doing and used it a lot for rectal cancer. The last thing that I'm going to talk about is the newer innovations that we're doing now for colorectal cancer on this left side in the rectum. It's called the NICE procedure. It stands for natural orifice, which we're doing more and more. This is basically taking the advantages of operating by the rectum, and instead of making an incision on the abdomen, what we're going to do is we're going to take the specimen out through the rectum. So this is another animation that we like to show our patients. We're basically saying, look, your cancer is over there by the left side. We're going to do surgery where we're going to put in these 3 or 4 robotic ports, these instruments. We're going to gain access to your abdomen, and this is just a very cursory look, but we basically say, look, we're going to go above the tumor, we're going to go below the tumor. We put in a special retractor through the rectum, and we're actually able to take the specimen now right out through the rectum, natural orifice. So the NICE procedure stands for natural orifice intracorporeal, which we're doing here. This is where we're patients are like, well, how do you put me together? Well, we have these cool tools, and we have the stapling device. We put the anvil in the left colon, we close the rectum, we join them, and it fires a staple line, and now we've completed the entire procedure without having an incision. And so this is really what we're doing very routinely for diverticulitis, for instance, because that's a great procedure for that, but now also for a lot of our colorectal cancers. And the patients look like they had a lap chole or a lap appy, and they behave that way too. As you can imagine, the chance of a hernia, the chance of surgical site infections, everything goes way down. This is a cancer right at the upper rectum, the rectosigmoid, and just showing just a minute here of this robotic video. Those are little lymph nodes because the gastroenterologist tattooed, we talked about tattooing earlier, they tattooed the cancer, and actually as a side effect, those little lymph nodes light up too. But this is just to show how precise and how beautiful visualization robotic surgery has. That's that blood vessel where all the lymph nodes live on. That one's called the superior rectal artery. And it's hard to appreciate, but we're starting to operate down into the narrow pelvis. We just get great manipulation, great visualization, very little bleeding, and it basically makes our life much easier, especially when we're operating in the pelvis. That's showing the tattoo mark by the cancer. We're using this device which seals and prevents bleeding. And once we get beyond the tumor, that's where we're right now just beyond the tumor, we have these beautiful staplers. It makes it much easier for us, where before it was a big struggle, now new technologies. So we stapled below the cancer, we now stapled above the cancer, and we used to now make a little incision to take out the specimen. But instead of that, what we're doing is the NICE procedure, where we're now going to use the rectum to extract the specimen. So we make a hole there in the rectum, we put in a retractor because, we have principles of oncology. We don't want any potential seeding of any tumor. We usually put that retractor on the abdominal wall. Now we put it in through the rectum. Then in through the rectum, we put what's called an endo bag. We deliver the specimen into this endo bag. And again, instead of making a traditional small incision, we're able to deliver the tumor through the rectum as a natural orifice. And then we call this kind of bag-in-bag technique because this really assures that there'll be no spillage or no cross-contamination. And as we take it out, we are going to then have to put the patient back together because now we have an open rectum. There's the tumor, there's the tattoo mark. And to put the anastomosis, we deliver the stapling device. This is what the animation was showing. We have to put one edge of the stapling device called the anvil in the left colon there. We secure it. And then we go back to the rectum to close that with another stapler. And then we're ready to do what's called the anastomosis, where we fuse the two ends of the colon together. There's the stapler, and we're just putting everything together. And that's how we do the surgery for many of these patients where we no longer have to make incisions. This is a flex sigmoidoscopy about 4 to 6 weeks after surgery. What does the anastomosis look like in these cases? It looks great. It's nice, wide open. It's healing very well. And so that's basically that. And the way the patients recover and the way the patients look after surgery is pretty much very close to the animation. They just have 3 or 4 little incisions, and there's no way. And I always tell them, if you ever go to the emergency room and they ask you if you had surgeries, they're going to think you're crazy if you said you had your rectum removed this way, because that doesn't look like a rectal surgery. But that's the way we're doing it now. So in summary, the treatment options, we individualize them. Every patient is unique and carries unique considerations. We have a multidisciplinary team and approach with our colleagues to really afford the patient the best care, and their surgical techniques are modernizing and they're evolving. I'm going to leave you with a 1-minute. So how's everything going?
Fine.
We did surgery just yesterday, is that right?
That's right.
Basically 24 hours ago. Did anybody tell you you're not supposed to look this good?
No.
So you're doing great and looking good. I want to know, what is your pain level?
It's right now, all day I didn't have no pain.
You didn't have any pain? Wow, your first day of surgery?
Actually, during the night I did, but when I woke up this morning, I didn't have any.
Wow. Can you tell on your belly where you had the surgery? Does it feel like a particular area real sore?
Yeah, but right here, I think, well, I don't know.
It's hard to tell, huh? You got all this good-looking food right there. The way our patients are recovering, it's quite amazing. They're doing great. I want to thank you again, Dr. Arrington and Dr. Esnaola, for inviting me, and more to come. Thank you.
For you, Dr. Haas, if the rectal cancer has been cleared by chemotherapy, is it possible that it's now necrotic and no surgeries needed? They'll wait and watch.
That's going to be the next symposium. It's called Wait and Watch. You're ahead of the game, whoever asked that question. There are breakthroughs in rectal cancer in terms of pre-treating, and then the cancer completely goes away. So there are cases for sure, and that's the next big breakthrough in rectal cancer, of doing treatments that don't involve surgery at all. So stay tuned for that.
And those patients are certainly presented at our multidisciplinary tumor board on a case-by-case basis.
They are.
All right.
Get the agenda up, please. Good afternoon. I'm Dr. Esnaola. I'm the Division Chief of Surgical Oncology at Houston Methodist Hospital, and I'm also the Surgical Director of the Cancer Center. We're going to continue with our symposium. So I think we've heard some great presentations so far, and we wanted to get to some topics that are a little bit more complex, but we think that they're of importance to primary care providers as well. These are things that are probably, conceivably a bit more technical, a bit more esoteric in some ways, but I think it's equally important that the folks participating in the symposium have a good understanding of the role of systemic therapy, radiation therapy, and also the management of patients with more advanced disease. I'll be beginning with a discussion about the role of surgery in metastatic colorectal cancer, specifically talking about the management of liver metastases. I have no disclosures. So I'll start the presentation with just a brief case presentation. This is actually a gentleman that took care of JS, 42-year-old man. As Dr. Haas mentioned, we see fairly young patients nowadays with rectal cancer, and he's no exception. He presented with intermittent constipation and blood per rectum. Colonoscopy showed a friable mass extending from 12 to 18 centimeters from the anal verge, a fairly large tumor. Biopsy was consistent with adenocarcinoma. He had a metastatic workup, as Dr. Arrington alluded to earlier, including a chest CT, a pelvic CT, and abdomen CT, and that revealed no lung metastases, a bulky rectal cancer with perirectal nodes, and bilobar liver metastases. So this is essentially what we saw in CT. We saw 3 separate liver metastases, 2 in the right lobe of the liver, segment 7, and then, 1 in the right lobe and 2 in the left lobe, 1 in segment 4 and 1 segments 2 and 3. Now, historically, that's a patient that would have been considered unresectable and incurable. This field has really changed dramatically over time. Oftentimes, we as surgeons do not participate in the care of patients with metastatic disease because they're not necessarily amenable to surgical resection. This is one exception to the rule, and in fact, we quote survival rates, long-term survival rates of 35 to 55% to these patients if their primary disease and metastatic disease can be completely resected. So why is this an important topic? It's important because about a significant proportion of patients with colorectal cancer will eventually present or develop hepatic colorectal metastases. And about 50% of the patients that will be isolated to the liver, and these are the patients that we're most likely to potentially cure. Chemotherapy alone can result in 5-year survival, but it's a very low rate, probably less than 5% at most, even with modern-day combination chemotherapy. So this is sort of just a run-through of what we'll be talking about today. We'll talk about the management of hepatic colorectal mets. I do want to talk about resection because it's still the gold standard. We'll talk about liver-directed ablative therapies. We'll talk a bit about systemic therapy, specifically systemic chemotherapy. I won't touch upon immunotherapy as much today. And then there's also potential roles for radiation therapy, but we won't get into those today. Again, this is a fairly complex topic. This is something that might take an entire day or a couple of days. At most academic symposiums focus on this topic, but I just want to make sure that I go through some important things that I think are important take-home points for the individuals participating at today's symposium. Again, pre-op staging, when these individuals are referred to us, it's important to do high-end CT scanning. So we normally do what's called a liver protocol or 4-phase CT with no contrast, arterial, venous, and then sometimes delayed images. We'll occasionally incorporate PET-CT scans. I wouldn't say we get this on everyone, but there's some studies suggesting that in selected patient populations, about a third of the patients will have additional lesions, and specifically lesions outside the liver noted on CT scan, and that's important to note. It's important for us to assess the extent of the disease, both the size and the locations of the tumors, whether they're what we call unilobar, just in one lobe, or bilobar, which is both lobes. And then we have to assess what's called the future liver remnant. And a lot of that is based on the underlying liver function because that determines how much liver we have to leave behind so that the patient has sufficient liver function to maintain optimal quality of life. With respect to resection, there's different ways of doing it, and I'll talk about this a little bit later on, but we can do what are called anatomic resections, where we take out a specific anatomic liver segment or even the whole right lobe or the whole left lobe. Or we can do what are called non-anatomic resections, where we essentially carve out a portion of the liver around the tumor with a certain margin. We have moved more and more to this non-anatomic approach, and the concept is to leave as much liver behind, and I'll show some information about that later. And again, this is a good technique if the lesions are smaller or superficial, but I would tell you that that's actually a technique that can be used for larger lesions and deeper lesions, especially with a lot of the new devices that are available to us. We use stapling devices that speeds up the procedure, so you may get a report that talks about staple lines in your patient's livers. That's not uncommon. And the goal of this, as with any other oncologic procedure, is what we call an R0 resection, where it's a resection with negative margins. Grossly, we aim for a 1 centimeter margin intraoperatively, but at least we want 1 millimeter pathologically at the end of the day. Now, just because you can do something doesn't mean that you should do something. Just because you can resect something, you shouldn't resect it. There have been efforts to resect metastatic gastric cancer, pancreatic cancer, and other cancers to the liver, and those patients unfortunately do poorly. Colorectal cancer, again, is an exception to the rule. The study that demonstrated that is this. This is actually a fairly old study from 1988. It was a retrospective chart review. It covered 24 institutions over a very long period of time, if you can see here. But it's actually the first study that demonstrated long-term 5-year survival in these individuals with resection. Now, the disease-free survival is a bit lower because these patients can sometimes recur outside the liver, so that's why you see those curves be slightly differently. That study really kind of set the criteria for who is or isn't a surgical candidate. It demonstrated that individuals with more than 3 lesions, tumors on both sides, had margins less than 1 centimeter, had enlarged lymph nodes outside the liver, or presented at the same time as their primary tumor didn't do as well. And I'll go over how a lot of these myths have been debunked, or a lot of this dogma has been debunked over time, especially with the addition now of systemic chemotherapy. Now let's talk a little bit about the number of metastases. Just because a patient has more than 1 lesion, it doesn't mean that they're not resectable or potentially curable. These are a couple of studies, one from Japan and one from the United States, showing that patients with more than 4 lesions can have good long-term outcomes. So again, the number of lesions is not as important as it is how much liver will be left behind after all those lesions have been resected or ablated. Margins, again, this study demonstrated that a positive margin is associated with worse survival over time, but the actual size of the margin is not as crucial. So as long as it's at least 1 millimeter in size, by the time we get the pathology report back, those patients can certainly enjoy long-term survival. Not all extrahepatic disease is unresectable. Some patients present with extension of a tumor of a liver metastasis to the stomach or other structures, extension to the bile duct. Patients can have recurrence, a re-recurrence in the liver or a new lesion, and can sometimes have extrahepatic disease. So the ones that we see most commonly are lung metastases and metastases to the peritoneum or the abdomen cavity. There are reports, of course these are highly selected patients, of long-term survival in individuals with both liver metastases and lung metastases. So again, metastases outside the liver are not necessarily contraindications to resection. Ideally, you want those folks to have single lesions and a disease-free interval between the liver and the lung metastases. Peritoneal disease, Dr. Arrington will discuss this as well, but that in and of itself is not a contraindication to liver resection, and the survival is primarily driven by the number of liver lesions, not so much the peritoneal disease, although obviously there are exceptions. This is a very common problem that we'll see. We oftentimes will coordinate closely with our colorectal colleagues and our colleagues in surgical oncology, but folks that have a primary tumor and a liver metastasis at the same time are a very tricky sort of combination. The important thing to remember is that if the tumor, the primary is of the liver disease or metastatic disease unresectable, there's really no reason to remove the primary tumor. The risk of post-op complications and the risk of tumor complications is really the same, and there's absolutely no survival benefit. So in general, when these patients present with disease that we feel as surgeons is not resectable, it's too diffuse, there's too many liver metastases, there's really no reason to remove the primary tumor unless they're obstructed or bleeding or whatnot. Those patients normally just receive systemic therapy. If the liver disease is resectable, in general, if they present at the same time as their primary, their prognosis is worse. Normally, we add upfront chemotherapy in these patients, and then we assess the optimal timing of resection of both their primary and their metastatic disease. This is a study in which we actually looked at outcomes in combined resection versus isolated resection. So in other words, is it better to resect their primary colorectal tumor and their liver disease at the same time, or to separate those two procedures? And the bottom line is that when you do the procedures jointly, the complication rates are much higher, specifically respiratory complications, deep space infections in the abdomen, as well as sepsis, which can sometimes be even life-threatening. So as a general rule, we separate these procedures if we feel that the extent of the liver procedure will be significant. Again, these are just theoretical advantages and disadvantages. Obviously, if you do the procedure In a composite faction where you resect both things at the same time, it's potentially more cost effective, but it's more morbid in general. Although it's conceivably less cost effective to do two separate procedures, the morbidity rate, and in fact the mortality rate, is much lower. So again, if the liver resection is more than just a simple wedge, we always separate the liver resection from the colorectal resection. We talked a little bit about the impact of type of resection that's performed. The general rule is that we do parenchymal sparing. We leave as much liver behind as possible. We aim grossly for a 1 centimeter margin. And as a general rule, a lot of these procedures, especially if they have multiple lesions or deep lesions, these procedures, although they can be done minimally invasively, sometimes they have to be done open to allow for this type of parenchymal sparing approach. So what are the new standards for resection? A lot of it has to do with, can all the disease be resected, and will the patient have sufficient volume of liver left behind? So I'm just going to quickly run through some common scenarios that we see. This is a patient with what we call bilobar disease. You can see a lesion on the right side of the liver and a lesion here's the lesion on the right, here's the lesion on the left. Obviously, we can't take out both lobes of the liver, and so the question is, how can we manage that patient? So one option is what's called liver-directed therapies using radiofrequency ablation, or now microwave ablation. The concept here is that this electrical energy or electromagnetic waves can heat the tissue and destroy the tissue. This can be useful for relatively smaller lesions, and sometimes we do it in combination with surgery if we don't feel like we can resect both lesions. This is what your patient might look like. So if you send a patient for surgery and you see them back, you may see a CAT scan report that talks about an ablation cavity on one side, and that's essentially what you'll see. There's a very dark lesion at the site of where a previous metastasis used to be, and you can see the portion of the liver that was resected there on the left side. As a general rule, patients that have complete resection do better than patients that have resection and ablation. So again, resection remains the gold standard. If we as surgeons feel we can resect all the lesions, we try to do so whenever possible. This is an example of what's called an extended hepatectomy, where we take out not just the right side of the liver, but a portion of the left side as well. And you can see we're leaving a very small portion of liver behind that we entitle the future liver remnant. We can actually have the radiologist do what's called a CT volumetric analysis. It can actually measure the volume of how much liver we're leaving behind. As a general rule, in a patient with normal liver function, you can actually take up to 80% of their liver and resect it, as long as you're leaving 20% behind. If a patients have underlying liver dysfunction or have received chemotherapy, that future liver remnant has to be at least 30% to minimize the risk of liver failure. This is an example of a CT volumetric analysis. These are actually some images generated by that software that I mentioned to you. In our patient, JS, the future liver remnant was less than 30%, and that patient had received pre-op chemotherapy, so we did not feel that he had sufficient future liver remnant to proceed with resection at that time. So we did something called a portal vein embolization. This was actually developed in Japan. They noted that patients with bile duct tumors encasing the portal vein led to shrinkage of that lobe of the liver and hypertrophy or enlargement of the contralateral lobe. And essentially, we do the same thing here. This is JS presented with an FLR of less than 30%. We did a portal vein embolization. This is done by our interventional radiology colleagues. They actually will cannulate the portal vein and occlude it with coils or glue or alcohol. This is what it looks like before the portal vein embolization. This is afterwards. You can see here how the branches to the right side of the liver have been truncated, and you see that the only residual flow at this point is to the left side. And what that does is it leads to hypertrophy of that lobe that you'll be leaving behind. You can see in this case that FLR went from 30% to 46%, which made that resection much safer. These patients, normally you have to wait at least 4 weeks, sometimes 6 weeks after the portal vein embolization. The complication rate is very low. I would say with very few exceptions, all my patients have always hypertrophied and been able to go on to resection unless they have disease elsewhere during that interim time period. This is a very common problem, technically unresectable disease. Can we use chemotherapy to increase the pool of patients that are deemed resectable? Systemic chemotherapy has really progressed tremendously over the last couple of decades, and some of my other colleagues will be talking about that later, so I don't want to steal their thunder, but the bottom line is that response rates have increased from 22% to up to 45% with modern-day combination therapy, as has median survival. But again, you can see here that rarely are these patients cured. They oftentimes will live, on average, about 2 years, but chemotherapy has become certainly much more powerful than it used to be in the past. How do we use neoadjuvant therapy or pre-op therapy? Traditionally, we use it after surgery. Sometimes we use it pre-op to either take patients who are resectable and get a better handle on the natural history of the disease before we do surgery, or we can try to convert them from unresectable to resectable. What are the benefits of chemotherapy beforehand? It gives us a handle on the natural history of their disease, especially if they present with lesions, the same liver lesions at the same time of their primary. It helps us assess the chemoresponsiveness of their tumor. In other words, how well does the tumor respond to the chemotherapy? There's different regimens that we use, so oftentimes we'll start with one regimen. If after 2 months we don't see diminished size in the tumor, we'll switch to the second regimen. It increases the chances that we'll get clean margins around the tumor. It may eradicate micrometastatic disease or microscopic disease that we're not seeing elsewhere. And also the response that we're seeing is a predictor of long-term survival. And so oftentimes we'll deploy this in patients, certainly with disease synchronous, but oftentimes in patients with disease that we think is of borderline resectability. Here's an example of a patient that presented with fairly bulky disease involving what's called a hepatic vein confluence, or the draining veins at the top of the liver, as well as the portal vein bifurcation, which is the inflow into the liver. This patient historically would have been deemed unresectable, would have been treated with systemic therapy alone, and would unlikely not have been cured. With pre-op chemotherapy, you can see dramatic shrinkage of these lesions, and this patient was then able to go on to surgical resection. When you look at the outcome of patients who are resectable up front versus patients who are downstage with chemotherapy and then go on to resection, the survival curves are a little bit lower. So in other words, 48% 5-year survival versus 33%. But again, you have to remember, without downstaging and surgery, that 5-year survival would have been close to 0%. So this is of tremendous benefit. This is not an uncommon scenario that we see. So it's very important to have these patients evaluated by both surgeons and medical oncologists up front. In terms of complication rates, actually complication rates have diminished over time. A lot of this has to do with the fact that as chemotherapy has improved, our intraoperative techniques and anesthetic techniques have gotten better, and you can see by that same token our negative margin resection rates have also improved. There are some risks associated with this. One thing to remember, and it's of particular importance to the participants in the symposium, is that oftentimes these lesions can disappear completely on chemotherapy. And so it's very important for these individuals to be evaluated by surgeons initially. Sometimes we'll actually put small markers at sites of disease that we think may disappear. And it's important to remember that something that's no longer radiologically visible is not necessarily associated with a pathologic complete response. In fact, the chance of that being the case is probably about 20%. In other words, about 80+% of those patients probably still have viable microscopic disease at that site in the liver. So it's important to still move on with resections in these individuals. So in summary, there's numerous treatment options for patients with liver metastases. These patients, as with colon cancer patients and rectal cancer patients, do need multidisciplinary evaluation. It's really crucial to have these patients evaluated by a cancer surgeon with expertise in hepatobiliary surgery as soon as possible. You don't need to make the decision as to whether that patient is resectable or not. Just send the patient to the surgeon, let that individual then decide what's appropriate or not appropriate. They'll work with their colleagues in medical oncology and radiation oncology to then sequence the care of that individual. High quality pre-op staging is important. Again, we're happy to make that decision. You don't have to worry about what scans to order. We can do that for you. Assessing the extent of disease is important. We oftentimes will use chemotherapy. Sometimes we'll incorporate ablation done by either the radiologist or by ourselves. And then assessing the future liver remnant is really crucial. Understanding the underlying liver function based on labs and imaging is important. Use of chemotherapy, portal vein embolizations, and then stage resection. So sometimes we'll do a resection of the right side of the liver, wait a month or two, and come back and do the other side. So that's another way of handling bilobar disease. Surgery, again, a negative margin resection is the goal, as with any other oncologic procedure. Post-op care, it's important to consider additional treatment of these individuals if they did not receive it preoperatively. And close surveillance is really crucial. I follow these patients, as Dr. Arrington, I'm sure, over a 5-year period, every 3 months for the first 2 years, every 6 months for the 5 years out, because oftentimes they'll develop new lesions and or they can recur at the sites of their initial resections. Many of these patients can be resalvaged with repeat resection or repeat ablation. So it's really very important to make sure that these patients don't fall through the cracks and continue to follow with their surgical oncologist moving forward. So I'll stop there and I'll cede the podium to Dr. Arrington. I'll be back at the end of today's symposium to answer any questions. Thank you.
Okay, the next talk is going to be on peritoneal disease, as Dr. Espinola mentioned. Let's see if I can get to it here. So one of the things that we do come across is stage 4 disease, where cancer has already went to the peritoneum. The first question is, what is the peritoneum? The peritoneum, this is the very thin lining. I describe it to patients as almost a saran wrap lining on the undersurface of the rectus sheath, and basically you're in all the abdominal cavity. And cancer cells can sit there and seed and then slowly grow. The problem with peritoneal carcinomatosis is that it's really hard to treat with systemic chemotherapy. What does it look like when I see it? And you'll see it on a report, and you'll send the patient to a medical oncologist. Please send the patient to me. But when we look in the operating room, what does it look like? It can look like widespread mets in the peritoneal cavity, this white thing, and this is colon here, and all these white, big firm things are big tumor nodules within the omentum and the peritoneal cavity. It can look like little, almost pencil tip size, miliary tumor nodules on the undersurface. So this is a laparoscopic view of the peritoneum with the bowel on the bottom of the peritoneal cavity. So this is peritoneal disease, very miliary in nature. It can kind of look like budding of the omentum itself. And here's another picture of tumor nodules within the omentum. It can look like jelly. One of the first indications for the surgery and surgical treatment of peritoneal disease was for low-grade appendiceal mucinous neoplasm back in the 80s, and this is what we were treating, was all this extensive mucin within the belly. In fact, we do call this jelly belly. So peritoneal disease, by definition, represents stage 4 disease of whatever cancer we're talking about. The most common things that I see are appendiceal tumors. Appendiceal tumors come in 2 different forms: benign, which relatively benign, meaning non-cancerous, not needing chemotherapy, low-grade appendiceal mucinous neoplasm. The traditional appendiceal cancers, and those come in 2 forms. One forms a lot of mucin, and one forms a lot of tumors. The signet ring type cells, cancers. Colorectal cancer is the second cancer. Nowadays, it's the most common type of cancer that I see with peritoneal disease. The ovarian cancer can have peritoneal disease, peritoneal mesothelioma. Those are the 4 groups that I see most often. There are a subset of gastric cancers that we've seen, that we've offered up surgical debulking with as well. They do not have as good as outcomes because these tumors are more aggressive. So with peritoneal disease and stage 4 cancer, as you can tell with all the other previous talks, it really is teamwork. It takes a multidisciplinary team to develop a treatment plan for these patients. It almost always involves systemic IV chemotherapy, either before or bridging the surgery itself. And what does the team look like? Well, the team is very widespread. You've got the patient in the center making an informed decision and being part of the treatment decision network. You've got tumor board members, cancer team members, the physician team, and that always includes the patient's primary care physician, because it does have long-term effects on the patient's quality of life, however long that is. What is the benefit of offering patients surgery for this widespread disease within the peritoneum? First of all, what is cytoreductive surgery? Well, cytoreductive surgery I can't really explain to patients what it is until we're in the operating room, because it's where we operate and remove any visible tumor. What that can include, first of all, what it always includes is if the gallbladder's there, we take the gallbladder out, and we do an appendectomy, omentectomy, peritonectomy, and any of these other organs that you can live without that has tumor. I tell patients it may come out. After all that cancer is debulked or removed with no visible disease, one of the options that patients may have, depending on their disease entity, is intraperitoneal chemotherapy. And the HIPEC is the word that is thrown around with this procedure. Well, why do we consider intraperitoneal chemotherapy at the time of surgery? Well, we've shown that surgical debulking alone is not enough in most cases. There are some European studies that have compared cytoreduction along with HIPEC, cytoreduction on HIPEC. First of all, the Europeans do not do what the more Western surgeons and HIPEC surgeons do for chemotherapy, so it's not comparable to what we offer here in the U.S. But we know that surgical debulking can palliate symptoms, but it can also, there's little benefit survival to just debulk. We know the tumors will come back. It might make the patients feel better. They might give them a quality of life for the time of life they have, but it is not going to be definitive care. Just to debulk tumor theoretically disrupts a tumor mass and increases the dissemination of cancer cells that we can't see throughout the peritoneal cavity. And it does cause a lot of scar tissue and can cause long-term issues with pain or partial obstructions potentially for patients with just debulking. Intraperitoneal chemotherapy, because the peritoneal lining doesn't have blood flow, there are no blood vessels that actually penetrate the peritoneum. Systemic IV chemotherapy has little effect, can really not get to those tumor cells on the peritoneum because of the blood supply and the low penetration into the tumor nodules. The rationale for intraperitoneal chemotherapy is you have direct contact of the cytotoxic drugs to the tumors itself without reliance on the blood supply. You have little, if any, systemic side effects because it's not given IV. So how is all this done and who actually qualifies for this? Well, first, again, is cytoreductive surgery, any macroscopic resection of all the tumor, whether we have to do bowel resections, we either take all of the peritoneum out or partial peritonectomy depending on the disease entity and the omentum. So again, this is the peritoneum on the undersurface of the abdominal wall, and it's literally just slowly peeling off the peritoneum, which is a very tedious procedure. But you can see all the tumor here, kind of on the surface of the peritoneum, and you can see that the peritonectomy is almost complete. You can by this time. And here's another picture of us slowly pulling off the peritoneum from the left hemidiaphragm. So after all the tumors removed, what is next? Well, the intraperitoneal intraoperative chemotherapy is next. And we add heat to this, so it's hot chemotherapy. And why do we do that? Well, heat is synergistic to platinum-based chemotherapies. It can help expedite impaired DNA repair, and you have deeper tumor penetration with whatever chemotherapy we offer. Theoretical advantages, again, it gets any floaters that I just can't see to remove. It gets any microscopic disease. It actually decreases in most patients the adhesions that are formed from the bulking itself, and there's a reduction in lag time of actual response to the chemotherapy. These are just the catheters that are inserted intraoperatively while the patient's asleep, and then we sew up the skin and start our infusion with a machine. and infuse hot chemotherapy and shake it around the abdomen. Some people call this the shake and bake procedure for 90 minutes to make sure that you get good penetration of the chemotherapy along all the surfaces, all the bowel that's still left in the abdomen. There are consensus statements, and this has progressed since the 80s, so there are standards for HIPEC programs and recommendations on the type of chemotherapy, how much chemotherapy, what time frame. I'm part of the Chicago Consensus Working Group, and we've developed several recommendations. Most generally, we use mitomycin C for 90 minutes at 42 degrees for most of our cancers. Ovarian cancer is a little different. It's a 60-minute infusion of a different chemotherapy. How does this actually translate into clinical medicine? Well, looking at the progression of chemotherapy in colon cancer, and again, one of our colleagues will talk about it, but I hate when people bring up Kaplan-Meier curves, but just in general, this is the kind of one of the progressions of chemotherapy, and you can see even though there's improvement with the addition of chemotherapy and all these lines, the lines are still close together, so there's improvement of survival, but to a degree of months. You know, when HIPEC came around, and you can see that the 50% overall survival for metastatic colon cancer can increase in these patients that are HIPEC candidates from potentially up to 5 years. So there is a significant delineation between those two groups on this Kaplan-Meier curve. Who qualifies? Again, we have a consensus statement. We all kind of work toward this. There are outliers that we can include on a patient-to-patient basis, but not all people qualify for the surgery. A small volume disease in the lesser omentum, more than one site in the liver, or less than 3 now, and if we would need to do more than one bowel resection for obstruction, those are probably the more rate-limiting steps. There are ways to determine prior to surgery how much cancer is on the inside and whether or not the patient would qualify. The peritoneal carcinomatosis index is the one that I use most often, and depending on, we divide the abdomen on the CT scan in all these quadrants and then quantify how much tumor is in all the quadrants and then add them by a numerical scale. In most cancers, anything over 15, I would strongly recommend systemic therapy to see if we can decrease the tumor burden before we go to consideration for HIPEC. PCI has been one of the predictors for outcomes. You can see the mean overall survival for a PCI of less than 10 is 48 months, and this is in colorectal cancer again. And the median overall survival for between 11 and 20 is 24. The 11 to 15 PCI number, you're looking at about a 35 month median survival. And disease type absolutely matters. Appendiceal, so the top two, pseudomyxoma and appendiceal. Pseudomyxoma and low-grade appendiceal mucinous neoplasm, this is a curative intent without systemic therapy. So some patients never need treatment after this. They need very, very close survival. Gastric cancer, more aggressive cancer, they do not have as much benefit for this particular procedure. Again, it takes a team, and we go through a whole algorithm to make sure that patients qualify and would benefit from HIPEC prior to ever getting there. So what you and the patient need to know, well, these are the highlights of what I tell patients initially to digest. The cytoreductive surgery in HIPEC is between a 6 and 16-hour procedure. It really depends on how much cytoreduction or debulking we need to do. The national average length of stay is 14 days. The chance of ostomy is almost 25% in most patients. There's a higher complication rate than just a colon surgery because we're doing more, up to 20%. They likely will need preoperative chemotherapy. It's not without its risk. The biggest side effects on it, that I have a very long discussion with patients, there's all kinds of side effects. They can be surgery-related, chemotherapy-related, or both. I think the biggest one is the prolonged decreased GI motility. So if you have a patient that is a high-PEG patient or a potential high-PEG patient, the biggest thing is, they've had multiple bowel resections, and they had chemotherapy all around their intestines. And I tell patients that their intestines are temperamental or bipolar, and it takes weeks to kind of settle down their GI motility, and diet changes and may have to happen for a few months after surgery just to get them back to a baseline. So that can be the biggest quality of life thing that patients see. It does get better post-operatively. So in summary, it really takes a village for any patient with any type of stage 4 disease, especially with carcinomatosis. It does improve overall survival. It improves recurrence-free survival. In appendiceal neoplasms, it can be curative. We decrease the risk of systemic toxicity, and organizing the team is absolutely essential, and everyone's involved. So with that, I will.
Thank you, Dr. Arrington, for that great summary. Dr. Arrington is an expert at the management of patients with these peritoneal malignancies and spearheads our cytoreduction and peritoneal malignancy program. So thank you very much for that presentation. Next, we're going to move on to the role of systemic and radiation therapy in the care of patients with colorectal cancer. We'll be talking about management or the role of systemic therapy. Dr. Muhammad Khalil will be giving that presentation. And then we'll talk about the role of radiation therapy in the management of patients with colorectal cancer, and specifically rectal cancer. And Dr. Wakar Haq will be giving that presentation. So we're going to go ahead and start with the role of systemic therapy.
All right, thank you very much. Thanks for everyone who joined in today. For the next 15 minutes or so, I'll be talking about the role of systemic therapy in colorectal cancer. And when we are talking about the systemic therapy, there are really three major disease settings that we usually focus on. The first is adjuvant chemotherapy in resected colon cancer, then adjuvant and neoadjuvant chemo in rectal cancer, and finally metastatic disease. So when it comes to adjuvant chemo in colon cancer, the question always is, why do we do adjuvant chemotherapy? The tumor has been removed. If we do any imaging studies, we can't see any tumor. And the answer is that certain diseases after resection, and depending on their stage, can have an increased risk of micrometastatic disease, which can later on progress and impact patient outcome. So the role of adjuvant chemo is to try to eradicate the micrometastatic disease and therefore reduce the risk of recurrence and hopefully improve survival. This is particularly important in more advanced stages of resectable colon cancers. So we're talking about stage 3, which is defined by node positivity, or stage 2 disease, which are tumors that are T3 or T4, but don't necessarily have nodal involvement. Earlier stage diseases, such as stage 1, typically has a low risk of recurrence and doesn't usually require adjuvant chemotherapy. So where did the adjuvant chemo start? It started with the use of fluorouracil. It's probably the most commonly used chemotherapy in the area of colorectal cancer. These are showing data from old studies from the 80s and 90s where 5-FU was used in patients with stage 2 and 3 disease. And basically, as you can see from here, that the overall survival was improved in the overall population. And that improvement is particularly important with stage 3 disease. With stage 2, the magnitude of benefit has always been less. And that always raised the question as to, do really patients with stage 2 need adjuvant chemotherapy? And if so, is there a way to sort out who would benefit more from adjuvant? This is the Mosaic trial that was published in 2004, which established the current standard of care for adjuvant therapy for stage 3 disease. In this trial, the oxaliplatin chemotherapy, which is a platinum that is active in colorectal cancer, was added to 5-FU in a regimen we call FOLFOX, and compared to the standard 5-FU at that time, showing enhancement in disease-free survival initially at 3 years. And then updated analysis of the study showed persistent improvement in disease-free and overall survival in the overall study population. When we look at stage 2 versus stage 3, to the right side of the slide here, you can see that this improvement in disease-free survival was mainly seen in stage 3 disease, but in stage 2 disease, the improvement did not reach statistical significance. Same thing applies for overall survival here. So basically, at this point, we've established that the standard of care based on this data set is FOLFOX, and that's been the standard for a long time now, given usually for a period of 6 months. And then for stage 2 disease, there's really no clear benefit of the addition of oxaliplatin, so the chemotherapy remains 5-FU. However, as we discussed earlier, not every patient with stage 2 disease may actually benefit from that. So how can we sort this out? Well, one of the ways we can do that is by looking at certain clinical or pathological features. Currently, if we look at the NCCN, they do recommend using a list of certain high-risk features as a way to define high-risk stage 2 disease. As you can see here, T4 lesions, presence of perforation, less than 12 nodes sampled, obstruction, poorly differentiated tumors, presence of lymphovascular invasion or perineural invasion. All of these are risk factors that increase the risk of distant metastases. The top 3, T4 and perforation and low number of lymph nodes sampled, tend to be probably the more important ones that translate into higher risk. So at this point, these are what we generally use as a way to sort out who gets chemotherapy and who doesn't among patients with stage 2. And then there is the concept of deficient mismatch repair enzymes. Some of these tumors are deficient in mismatch repair enzyme, and the DNA signature of that is what we call microsatellite instability. So we call these patients MSI high. So patients whose tumors show this alteration are about 15 to 20% of cases. Generally speaking, they have a better overall prognosis and therefore derive less benefit from any adjuvant therapy. And interestingly, these tumors have a distinct biology that makes them less susceptible to 5-FU. And therefore, these tumors are generally not treated with adjuvant therapy as a general rule, although there might be some exceptions here and there depending on specific characteristics. And then other ways we can look or sort out stage 2 disease using methods like gene expression profiling or circulating tumor DNA. These are currently areas of interest. Gene expression profiling, there are multiple assays available that can provide information about the prognosis. So they're mostly prognostic. However, their predictive value in predicting benefit of adjuvant chemotherapy is not really yet established. So Gene expression profiling as well as ctDNA is, those are interesting concepts that are undergoing a lot of research these days, but are not used currently as a standard way of sorting out adjuvant therapy for stage 2. So in summary now, we know that patients who need chemotherapy are those with stage 3 disease, who have node-positive disease, or stage 2 with high-risk features and proficient mismatch repair. So they don't have the MSI high or the deficient mismatch repair that we talked about earlier. The next concept adjuvant chemo is really the duration of chemotherapy. So we discussed previously that 6 months has been the standard for a long time. The problem with this chemotherapy, particularly the oxaliplatin component, is the cumulative neuropathy that patients get, which tends to be the most prevalent side effect of oxaliplatin, particularly once we start crossing the 3-month point, which limits the treatment and results in potentially long-term quality of life issues for those patients. So this is a collection of, this data comes from up to around 6, I think there are 6 studies that looked at reducing the duration of adjuvant chemo from 6 months to 3 months, and looking at the different groups. Most of these studies used FOLFOX or CAPOX, which is a regimen that has been for a long time considered equivalent to FOLFOX. The difference is that instead of the infusional component, which is 5-FU, it's replaced with an oral prodrug called capecitabine that is metabolized into 5-FU and produces similar effects. So in this analysis, they looked at FOLFOX versus CAPOX groups and looked at stage 3 divided by high and low risk subgroups, as defined by T4 and N2. So those are higher risk stage 3s, and T1 to 3 and N1 being considered lower risk group. And this was designed as a non-inferiority to see if 3 months is really non-inferior to 6 months. And the non-inferiority was not met with the exception of the lower risk group, stage 3, and under the CAPOX arm. So basically, if a patient with stage 3 who is a low risk and was treated with CAPOX, 3 months seems to be non-inferior to 6 months in this analysis, which opened the door for this concept of using less chemotherapy in certain patients who meet these criteria. So in summary, when we talk about adjuvant, this is kind of the general outline of what we are looking at. Stage 3, if it's high risk, with the higher T nodal and T staging, the standard is to use FOLFOX or CAPOX for 6 months. Lower risk stage 3s can be treated with the same standard of FOLFOX for 6 months, but they do have the option of using 3 months of CAPOX that can provide reduced toxicity. Patients with stage 2, as we mentioned earlier, we look at the high-risk features. If they're high risk and they're proficient in mismatch repair enzymes, generally they're treated with a 5-FU or with the oral capecitabine for up to 6 months. And the ones who do not have high-risk features or have deficiency in mismatch repair or MSI high do not get any benefit from adjuvant chemo and usually are managed with observation. Now, shifting gears to rectal cancer. So when it comes to rectal cancer, one of the main differences is that there's this issue of local recurrence that becomes a major issue in rectal cancer compared to colon cancer. So when we're talking about adjuvant therapy, typically we employ chemo, but we also add radiation therapy. Radiation traditionally has been given in combination with chemotherapy for a period of time, followed by chemotherapy. And this used to be the old standard that after surgery, patient would get combined or concurrent chemoradiation followed by chemotherapy. And a major study called the German Rectal Cancer Study Group looked at moving chemoradiotherapy to the preoperative setting and looking at improvement in outcomes by doing the chemoradiotherapy up front. And the major advantage of this approach is significantly improved local control with reduced pelvic recurrence, as you can see in the top left here. But when it comes to disease-free survival overall and distant metastasis-free survival, there doesn't seem to be any difference. So really the main benefit of doing that is with enhanced local control. And then that established a standard of treatment for a long period of time where patients would get neoadjuvant chemoradiation, and then they go for surgery, and after that, they might get chemotherapy for up to 6 months. Currently, the NCCN guidelines recommend up to 6 months of perioperative chemotherapy as a total duration of therapy. That original study, used 4 months of 5FU. We know that there is an advantage of adding oxaliplatin as an extrapolation from the colon cancer data, either adding oxaliplatin or not is one of those issues that can be a little controversial in certain situations. But currently, the overall, the current guidelines as per NCCN is to use FOLFOX or CAPOX for up to 6 months total in the adjuvant setting. Next I'll move to the concept of TNT, or total neoadjuvant therapy. So for the past few years, there has been growing interest in moving all of the treatment before surgery. So all of the chemotherapy and radiation up front, particularly for patients who might be at higher risk, such as T4 or T3 that have some adverse features on imaging, on clinical initial staging, that might predict a higher chance of positive margins at resection and node-positive disease. And in such cases, the benefit of moving everything up front, including all of the chemotherapy, can be because of improved compliance. A lot of patients who undergo surgery can have prolonged recovery, and traditionally it's been challenging to give chemotherapy after rectal surgery to many patients, or giving it in a certain period of time. So giving chemotherapy up front tends to improve the ability to deliver chemotherapy, deliver it fully, and potentially even give more intensive regimens. It also, neoadjuvant therapy provides the opportunity to treat metastatic disease or micrometastatic disease early on in the treatment. It provides an in vivo opportunity to assess sensitivity of the tumor to the chemotherapy, since the tumor is still there and we can observe its response to chemotherapy. And then it opens the door for a concept of non-operative approach, which is beyond the scope of this talk. But there are data that show that patients who achieve excellent results from their neoadjuvant chemo and chemoradiation tend to have very good outcomes, and people have been trying to look at the option of monitoring these patients carefully and only operating or intervening if something shows up later on. But these are some of the potential benefits of using total neoadjuvant therapy. This carries a lot of unresolved questions yet. We don't know, for sure what is the best sequence. Do we do it before radiation? Do we do the chemo after radiation? How long do we give chemotherapy? A lot of the durations of chemotherapy that have been employed are extrapolations from older data in different settings. Current trials, you can see durations of chemo given anywhere from 3 months to 4 months or even longer. And then what exactly is the right regimen? Do we use 5FU and capecitabine, FOLFOX and CAPOX, or combine the irinotecan with oxaliplatin in a more intensive regimen, FOLFIRINOX, which could potentially enhance outcomes and can potentially be given in the neoadjuvant setting, a regimen that would be very challenging and very difficult to give post-operatively. So these are a couple of examples of some studies that try to look at, try to answer some of these questions. This is, for example, a study that tried to give FOLFIRINOX, a more intensive regimen upfront before even the radiation therapy. So chemo, then radiation followed by surgery, and then followed by lesser intensity chemotherapy. And this was compared to a standard approach. And in this trial, 3-year disease-free survival and metastasis-free survival both improved with the more intensive chemotherapy regimen. This is another study looking at the sequencing of chemo and radiation. If chemotherapy is given before or after, and while it doesn't look like disease-free or metastasis-free survival is any different, organ preservation looks to be better with consolidation or chemotherapy that is given after radiation, for example. So this is another example where sequencing can influence the outcomes. Now, in this particular case, it's not necessarily clear why that is. Is there any unique thing about giving chemotherapy before or after, or is it simply the duration that is introduced, or the time that is introduced between radiation and surgery by giving the chemotherapy afterwards? Since we know that the longer we wait after radiation, the more response in the tumor. So that could be a reason, but it's nonetheless an interesting finding that all of these different modifications of the neoadjuvant approach can have significant outcomes down the road. So in summary, for rectal cancer, so we're looking at 2 major settings where we use the chemotherapy. We have the standard approach, or the conventional approach of giving radiation with or without chemo before surgery, and then giving the chemotherapy afterwards. But then more and more with higher risk diseases in particular, we're moving all of the treatment up front and all of the chemotherapy to the neoadjuvant setting. And then lastly, I will be talking about systemic therapy in the 3rd major setting of colorectal cancer, which is the metastatic setting. When we're talking metastatic disease, there are 2 major categories we think of when we talk about metastases. There are those operable patients who have limited metastases who could be approached with an intensive curative approach. And then there are patients who are treated with a palliative intent, patients with more advanced disease that are non-operable. So my focus here is mostly on the second part, which is the non-operable patients who are treated with palliative intent. Generally, these patients are treated with a goal of palliation, improving quality of life, but at the same time, trying to prolong their survival. So all of these treatments that we use in systemic therapy tend to have that benefit of prolonging survival, but we have to be always careful about how that is affecting patients' quality of life, as we have to kind of balance both things at the same time. So I'll be giving an overview of the different categories of systemic therapies that are used in this setting. Of course, there are a lot of details that are probably, there's no time for them at this point, but we'll talk about the general concepts of these therapies and some of their most important toxicities. So the first thing is chemotherapy, which is the traditional systemic therapy that we think about. With chemotherapy, there are different regimens that are commonly used. FOLFOX is the one that we've heard about from the adjuvant setting. But then with the metastatic setting, there are, of course, more options. Irinotecan is a commonly used chemotherapy that can be added also to the 5-FU in a combination that is called FOLFIRI. and either FOLFOX or FOLFIRI are generally considered similar in terms of efficacy in the colorectal metastatic setting, and they do differ though in their side effect profile, which is one of the things that we use to decide on which chemo regimen to use and which one might suit one patient more than the other. Irinotecan, for example, is more associated with diarrhea, neutropenia, alopecia, steatohepatitis. Sometimes oxaliplatin, on the other hand, has the major side effect of neuropathy, which tends to be mostly sensory and cumulative over time. This can be alleviated significantly by using different strategies while giving the chemotherapy. Mainly a stop-and-go strategy has been commonly used, where the oxaliplatin is stopped after a certain period of time. Patient takes a break from it. Other components of the chemotherapy, like 5-FU, are usually continued, and then the oxaliplatin can be reintroduced later on. This can be done without really compromising the overall effectiveness of the regimen or the outcomes of the treatment, while at the same time significantly reducing the toxicity. So this is just to show how, giving chemotherapy and treating metastatic patients utilizes slightly different approach and concepts, where we're trying to balance the long-term toxicity, since these patients are going to continue to have this disease and continue to be on the treatment for a significant portion of their life. Other significant side effects of oxaliplatin to be aware of is the hepatic toxicity, sinusoidal injury, which is particularly important in patients who are potential candidates for liver metastases resection, as this can influence their surgical outcomes. So this is one of the areas we try to limit exposure to oxaliplatin before surgery. And then there are additional reactions, infusion reactions, and other forms of toxicity we see with oxaliplatin as well. Capecitabine is another oral agent, which we talked about before, that can be combined as well with oxaliplatin in a regimen called CAPOX, and those tend to be the most commonly used combination chemotherapy regimens. Additional drugs can be added, with the goal to enhance outcomes, and bevacizumab is an example of that. It's an antibody, targets vascular endothelial growth factor, that can be added to either of those chemotherapies that we just discussed, and it does improve progression-free and overall survival. But the downside is that we always have to take into account all the potential toxicities that come with it, and monitor for those toxicities. Because it's an anti-vascular endothelial growth factor, it is associated with potential significant bleeding, thrombosis, bowel perforation, impaired wound healing, hypertension, and proteinuria. So those are some of the things that can sometimes limit our ability to use the drug, or result in us stopping it later on down the road because of any of these complications. Then there are antibodies that target EGFR, endothelial growth factor receptor, which plays a role in cell growth and proliferation in cancer cells. And by blocking this pathway using an antibody to EGFR, this can also enhance our outcomes. These, just like we saw with the bevacizumab, these are drugs that can be added to combination chemotherapy or other types of chemotherapy. The main two that have been used are cetuximab and panitumumab, both of which have shown significant clinical advantage. A couple of things to note about EGFR inhibitors is the fact that there are certain molecular findings that certain cancer cells can carry, such as mutations in RAS and BRAF, that predict resistance to these drugs, and therefore those should be tested before using The other important thing is the sidedness of the tumor. These drugs tend to be less effective or not effective in patients who have their tumors on the right side proximal to the splenic flexure. So these are more suited for left-sided tumors and RAS, BRAF wild-type tumors. They do come with certain side effects and toxicities, primarily infusion reactions and allergic reactions tend to be the most important ones. And then immune therapy is a major topic in metastatic colorectal cancer, just like in many other cancers these days. A small fraction of those patients who have the deficient mismatch repair enzymes or MSI high do respond well to these immune therapeutic drugs. These are what we call checkpoint inhibitors. Good examples here, a couple of studies that I'm showing are pembrolizumab and nivolumab, which was combined with another drug called ipilimumab. Those are immune therapeutic drugs that are non-cytotoxic, and in certain patients who carry these molecular alterations, they tend to be effective in the upfront setting. So that's an option. And that also highlights the importance of testing and characterizing the biology of the tumor upfront to select the best treatment possible. And they do also have the advantage of reduced toxicity compared to conventional cytotoxic chemotherapy. So this doesn't cover everything, but this is the kind of an overall summary of the different categories of systemic therapies. We talked about chemotherapy as single agents or combination, the addition of certain antibodies to chemotherapy backbone, like anti-vascular endothelial growth factor or EGFR, and then immune therapy in certain in a subset of patients. And then at the bottom there, you can see there are additional drugs that can be used. Most of these have been utilized in later lines of therapy in patients who are refractory or
Sorry to interrupt. We just need to, we're running a little bit behind. So if I can just ask you to just kindly just summarize so we can move on to the next presentation. I just want to make sure that we stay on schedule so that folks have a chance to do the question and answer session before we close at 12:30. Thank you.
Yeah, thank you very much. This is actually the final slide. So thank you.
Okay, thank you very much, Dr. Khalil. That's a very complex topic, and I think that was a really great summary of sort of how we think about these patients. There's a tremendous amount of refining and sort of precision care that goes into the management of these individuals. So the next speaker is Dr. Waqar Haq. He's one of our radiation oncologists, and he'll be talking today about the role of radiation therapy in the care of patients with colorectal cancer, and again, specifically mostly rectal cancer. Thank you.
Hello, good morning. Thank you, Dr. Esnaola, and thank you for the introduction, and thanks for the opportunity to be here and speak with you today. So I want to talk about radiation therapy for colorectal cancer and primarily rectal cancer. This will be a brief overview about the indications of radiation, logistics of radiation, side effects of radiation, and some data about how we got here. So radiation therapy is primarily indicated for patients with localized, is not usually indicated for patients with localized colon cancer. However, it is often a component of treatment for patients with locally advanced rectal cancer. So what that means is that typically for patients who have rectal cancer, radiation therapy for locally advanced disease is often used in the neoadjuvant setting. It's not typically used for patients who have more proximal colon malignancies. So this is just a snapshot of the current NCCN guidelines for colon cancer. Just wanted to reinforce, and I think as you guys have already heard today, for colon cancer, primarily, typically chemotherapy can be used, surgery is used up front when resectable. Radiation therapy is primarily only used in the locally unresectable or medically inoperable setting for local control. So radiation therapy is not not commonly used for most patients with colon cancer. However, with rectal cancer, radiation therapy is a more common component of treatment. This is a similar snapshot of the NCCN guidelines for patients with locally advanced rectal cancer. And what I wanted to highlight here is that neoadjuvant therapy typically includes radiation, either in conjunction or with chemotherapy or before or after chemotherapy. But radiation therapy is basically a component of the neoadjuvant management for patients with locally advanced rectal cancer. So, before I talk a little bit more about the details of radiation itself, I did want to talk about briefly some of the data that and studies that have been done that demonstrated the benefit of radiation therapy in the neoadjuvant setting. So one of the first trials that demonstrated a benefit of radiation therapy in the adjuvant setting actually was started, I think, in 1971, published in 1985, so about 30 years ago. 37 years ago, actually. So in this trial, patients with rectal cancer were treated with surgery and randomized to either neoadjuvant treatment, postoperative radiation, postoperative chemo, postoperative chemoradiation. And what they found was that compared to the observation arm at 10 years, there's a significant overall survival benefit with the use of chemoradiation. Then building on this trial, the next trial basically looked at adjuvant treatment with either radiation alone or a combination of chemotherapy and radiation. This trial was published in 1991, and what this trial showed was that there was an improved overall survival with chemoradiation alone compared to radiation alone. So chemotherapy and radiation became a standard of care in the adjuvant setting for patients with rectal cancer. So this kind of changed, or something that changed in the, I think, 80s/90s for the management of rectal cancer was something called total mesorectal excision. So this is essentially a sharp dissection along the visceral pelvis fascia and a complete removal of the rectum and surrounding mesorectum. This was one of the biggest breakthroughs, I think, in the past 50 years, probably, in the management of rectal cancer, and this substantially reduced the local recurrence and improved overall survival for patients with rectal cancer. So one thing I wanted to highlight, some of the earlier trials I mentioned showed a survival benefit with the use of adjuvant radiation for patients with locally advanced rectal cancer. But what I did want to highlight is that was in the pre-TME era. So one question that was asked is radiation therapy beneficial in the era of total mesorectal excision, which is a fair question. So the answer was this question was tried to be answered, I think, by the Dutch rectal cancer trial. In this trial, patients randomized to either TME alone or TME preceded by radiation therapy. And importantly, there was no difference in overall survival seen at 5 years. So I think one thing that's important to note is that the neoadjuvant radiation does not improve overall survival for patients with locally advanced rectal cancer in the TME era, unlike the earlier trials that were done in the pre-TME era. However, there was a decreased local recurrence risk with radiation, so therefore radiation therapy does reduce the risk of a local failure, but there's no improvement in overall survival with the use of radiation therapy, again in the TME era. So the next question that was asked is preoperative radiation superior to postoperative radiation? And this question attempted to be answered in the German rectal cancer trial, which is probably one of the most important trials in rectal cancer with respect to radiation therapy, at least, in the past 30 years. So this trial was published, I think, in 2004, and in this trial, patients with locally advanced rectal cancer were randomized to either preoperative chemoradiation or postoperative chemoradiation. There was no difference in overall survival, but there was a decreased local recurrence rate with the use of preoperative chemoradiation, and also a decreased toxicity with preoperative chemoradiation. So neoadjuvant or preoperative radiation chemotherapy became a standard of care as opposed to postoperative radiation. Also, one important outcome of this trial was that the rates of sphincter-sparing surgery was greater in the patients who had preoperative chemoradiation. So basically, amongst patients whose surgeons evaluated before neoadjuvant treatment, and amongst the patients who felt in whom surgeons felt like they could not do a sphincter-preserving surgery, the rate of sphincter preservation was higher in patients who got the preoperative chemoradiation. So that's another benefit of the neoadjuvant treatment. In addition to local control, it's perhaps a greater rate of sphincter-preserving surgery. So, I think there's a lot of work being done now about the sequencing of chemotherapy and radiation. I mean, in the sense that there's some data trying to do something called total neoadjuvant therapy, which is when they do all the chemotherapy before surgery. And then another thing I did want to touch on is at least the duration of radiation. So the German rectal cancer trial did what's called conventionally fractionated radiation, which is basically 28 treatments. The Dutch trial that I mentioned earlier did what was called hyperfractionated radiation, only 5 treatments. So, whether, hyperfractionation or conventional fractionation is superior is an active research question, but this trial did look at total neoadjuvant treatment with short course radiation and chemotherapy, and then surgery, or conventionally fractionated radiation, surgery, and then did adjuvant chemotherapy, depend on the hospital policy. So I think it's important to note that this trial at least did not compare short course radiation and chemo to long course radiation and chemo. It compared short course radiation and chemotherapy to long course radiation neoadjuvantly, and then possibly chemotherapy. Importantly, there was no difference in local control. Disease progression was decreased in the short course. The arm of patients who got short course radiation and neoadjuvant chemotherapy, probably because there was, not all patients in that in the long course radiation arm received chemotherapy. But I just wanted to bring this trial up. This trial published, I think, 2021 last year. But I just want to bring this up because there is moving a lot of data supporting the use of hyperfractionation as well in the neoadjuvant setting. So logistics of radiation, typically 5 to 25, sometimes 28 treatments. Patients typically undergo CT simulation or a planning CT scan in the treatment position prior to initiation of radiation so that we can draw out the internal anatomy of patients to help us design the radiation treatment. Each treatment typically lasts about 15 minutes. Side effects of radiation include nausea, vomiting, diarrhea, enteritis, proctitis, dehydration. So typically the radiation side effects are localized to the area we're treating, which is primarily in the GI tract. So there are some things we do to minimize toxicity, patient positioning, and radiation technique. So patient positioning, so patients can be treated either in a supine or prone position. For patients with rectal cancer, we oftentimes place them in the prone position, which offers the advantage of movement of small bowel superiorly and anteriorly away from the treatment field. So as the small bowel moves away from the rectum, there's hopefully less small bowel in the treatment field and consequently less toxicity. So this is some axial CT slices that try to demonstrate this. So on the left, we have patients in the supine position, and the turquoise lines basically are lines that encapsulate a certain amount of dose that the patient receives within that surface area or that volume. And basically, I just wanted to illustrate that in the supine position, there's some small bowel that can fall into the treatment field and therefore get some radiation dose, whereas in the prone position, the small bowel falls out of the radiation field, so hopefully there's less radiation dose to the small bowel in patients who are prone, and this can lead to reduced risk of side effects during radiation and after radiation. So radiation technique, one type of radiation that can be done is 3D conformal radiation, which is basically less beam modulation. The beams typically have straight edges. There's less ability to curve around anatomical structures, and consequently, there's more small bowel in the field. In some cases, we can use intensity modulated radiation therapy. This is basically where we use software to modulate the radiation beam to curve around concave and convex structures, and this can minimize radiation dose to the small bowel and to the surrounding normal structures. So this is just kind of a schematic, and on the left-hand side we have isodose line from an IMRT plan, and basically I just wanted to show how the dose can kind of curve around some of the small bowel, whereas in a 3D conformal plan the dose is more kind of angular and there's less ability to curve the radiation dose around small bowel. This has been shown to reduce the risk of toxicity. So this paper suggests that compared patients treated with IMRT and 3D conformal radiation, and there was less diarrhea and enteritis, and GI toxicity in patients who had IMRT as compared to 3D conformal radiation. So yeah, so that's my presentation, and thank you so much for having me, and I really appreciate this opportunity to talk to you guys.
Thank you, Dr. Hawk. So finally, we'll be finishing up with a series of presentations. focused on colorectal cancer survivorship. So as we mentioned before, these patients require complex care, oftentimes a combination of surgical, systemic therapy, and radiation therapy. We do follow them, obviously, with respect to cancer surveillance, but there are some implications with respect to quality of life with these various treatments that we think are important to discuss, given the focus today on primary care, because these are issues that will likely come up in the care of these patients on your end as well. So we're going to quickly cover the implications of systemic therapy, surgical therapy, and radiation therapy in these individuals during the survivorship period. And the first speaker today will be Dr. Mayan Abdelrahim, who will be speaking remotely about the impact of systemic therapy.
Thank you, Dr. Nawala. Let me share my slides. Can you see my slide? Okay.
We can see your slides. Can you change the display settings? We see that. There you go.
Okay. Can you see the PowerPoint presentation now? Awesome. Well, great. Good morning, everyone, and it's a pleasure to be with you today here. And today, this section is going to be shared by me and my colleague as well. So I'll try. I'll respect the time, and I will be like, precise, maybe like 12, 15 minutes at the most. So very important topic. And as we all know, that treatment of colorectal cancer now has improved significantly for the past decade. And this is because of improvement of imaging, surgical techniques, and chemotherapy. In addition, also, there is adding an immunotherapy that's an important modality for treatment of colorectal cancer over the last 5 or 10 years. With that being said, there is now 1.5 million survivors of colorectal cancer in the United States, based on the American Cancer Society. The relative survival rate for CRC is about 64% at 5 years, and it can go up to 58% at 10 years. So those patients live longer time. And as you can see from this figure, that patient with local disease, regardless of ethnicity and race, the 5-year survival actually can reach 90% for local disease. For a disease that is regional, the survival rate at 5 years, in average, can be 65 to 70. For patients with distant metastasis or stage 4 disease, the 5-year survival is around 15 to 17%. However, this is based on the 2009 and 2015. And as I mentioned earlier, immunotherapy, targeted therapy has been incorporated for treatment of those patients, and that led to increase of their survival. So the number of distant metastases, 5-year survival, 15% might be really longer. From this figure, you can see that majority of stage 1 and 2 colon cancer patients are actually treated with colectomy without chemotherapy, which stands for 84%. On the other hand, stage 3 disease is usually lymph node positive. They usually receive adjuvant therapy, on average 66%. And for stage 4, actually, it's a mixed bag of the above: surgery, chemo, and chemoradiation. On the other hand, for rectal cancer, 61% of stage 1 patients have actually a proctectomy or proctocolectomy, resection of the rectum or rectum and part of the colon. For stage 2 and 3 rectal cancer, we usually treat those patients with chemoradiation in the new adjuvant setting. And over the last maybe 5 years, there's an interest on what we call it TNT. Basically, you give everything up front, treating them with chemoradiation, then chemotherapy, and followed by surgery, and nothing after that. Or independent in the case, they might give some, adjuvant therapy, but short course, which is different than what we see from colon cancer. Excuse me. For stage 4 colon or rectal cancer, chemotherapy is the most important treatment modality. Targeted therapy can also be offered based for selected patients, which mainly include targeting VEGF pathway with Avastin and other similar drug or biosimilars, or treating with cetuximab targeting the EGFR pathway, or more recently, immunotherapy can be given based on the tumor molecular profiling or characteristic, if you will. If they are eligible for immunotherapy, patient will receive immunotherapy based on MSI status and mismatch repair genes proficiency or deficiency. So despite the potential survival benefit from chemotherapy can cause a significant side effect and toxicity. Usually, like chemotherapy for colorectal cancer, most of them, they have a GI, or they have what you call the GI side effect that includes mucositis, nausea, vomiting, diarrhea, neutropenia, which is general for most chemo, fatigue, hot-foot syndrome, and cardiotoxicity. Luckily, most of these symptoms are actually reversible when we stop the chemotherapy. So when the patient finished chemotherapy and we follow them in our survivorship clinic, and by the time they came into the primary care physicians, luckily most of these symptoms are going to be resolved. However, late and long-term effects of CRC-specific cytotoxic agent are relatively infrequent, but with the exception of few drugs. And today I'm going to just highlight the most important one, which is likely to be seen in your clinic when you see those patients after they finish oncological therapy for their cancer. First one is oxaliplatin-related peripheral neuropathy, and the second one is targeted therapy-mediated cardiomyopathy. We all know that oxaliplatin is really associated with dose-limiting and late onset symmetrical distal, what we call it, stocking glove pattern, axonal neuropathy, typically without any motor involvement. It has been shown actually up to 90% of our patients receive 6 months or more of oxaliplatin containing regimen will develop a neuropathy during their treatment. The good news, neuropathy is generally reversible. The bad news is actually it might take several years. And I tell my patients sometimes, even after many years, you might have a new baseline of neuropathy. Most patients actually, with time, they live with it, especially like if they reach, like a 10% of neuropathy that's left from their baseline, that is, for most, is 0. But for some, they might have other reasons for neuropathy, like diabetes and other diseases. So usually when they go to their baseline, it varies. It can be reaching multiple years. However, it gets better the far you are from the last dose of oxaliplatin. One systemic review of 27 studies actually have shown that both prevalence of persistent chemotherapy-induced peripheral neuropathy, we call it CIPN, of any grade after oxaliplatin-containing chemotherapy, it was reported at 58% at 6 months, 45% at 12 months, 32% at 24 months, 2 years, or 24% at 36 months. In average, there's a decrease of 26% per year after the chemotherapy cessation. And the neuropathy for oxaliplatin actually induce or include numbness, tingling, and cold-induced pain. Persistent neuropathy symptoms can negatively impact the quality of life, and that affect we can start seeing actually like colorectal cancers in the young generation and who are functional and they have jobs. So this can affect their quality of life and affect their job for some. So it is an important, side effect for those patients treated with oxaliplatin-based therapy. And actually, during their course of treatment, we monitor those patients, and when we see there is, an increased level of neuropathy, we end up decreasing their dose of oxaliplatin. And at some point, we might drop oxaliplatin if we feel that the risk and benefit is imbalanced from the side effect of oxaliplatin. How we treat this? Actually, most patients do not require specific treatment. Regular physical activity should be encouraged. And for patients with persistent painful neuropathy, treatment with duloxetine may be beneficial. However, the response to duloxetine can vary. Some patients really like it, do significant improvement in their side effect. However, for others, it's minimal. And for some, you didn't see a benefit after a few months. But usually, you have to wait some time to see the effect, more than at least 6 to 8 weeks. Other anticonvulsants or antidepressants have been used to treat neuropathy, and the benefit is vary from one patient to patient. However, the benefit had not yet proven in large trials. This is in small studies or practice-based for the treating oncologist or the primary care physicians. We use, actually in my practice, I use gabapentin on a titrating dose, and Lyrica is another drug that I use, and I have some success to treat neuropathy from oxaliplatin for my patients. Scramble therapy, which is what you call pain management approach, that actually block the transmission of pain signals by providing a non-pain information to nerve fibers that have been receiving pain messages. In a simpler way, it is basically overwhelming pain information with non-pain information in your nerves. And these, stimuli can be placed on the affected area, which is mainly in the fingers or in the legs and sometimes in the feet. So it has shown some success. However, proof benefit has not been provided yet as a clinical, or large clinical trial, if you will. Acupuncture, which we are all familiar with, sometimes can diminish the established neuropathy symptoms and appear to be actually a safe approach if you want to try it for your patient. Similar to before, proof of benefit has not been provided. The other group of medicine that affect a long-term or toxicity for patients treated for colorectal cancers is HER2 targeted therapy, mainly trastuzumab-associated cardiomyopathy. We all know that trastuzumab associated with symptomatic or asymptomatic reduce in the left ventricle ejection fraction and heart failure. So when we treat our patient with trastuzumab, we basically do an echo and we evaluate our patient before or during the treatment. And if we see signs of cardiomyopathy or heart failure, we usually discontinue the treatment. Trastuzumab is also associated with other side effects, including arrhythmias, hypertension, mural thrombus formation, stroke, and even cardiac death. Luckily, cardiomyopathy actually, due to trastuzumab, is generally reversible. And in 1 to 3 months, after discontinuation, usually these symptoms or cardiomyopathy is actually improved and go back to the baseline. In a study was published in 2014, they showed that the long-term, which is around 8 years, follow-up on adjuvant setting, in this case, trastuzumab for 1 to 2 years, given sequentially following chemotherapy or radiation therapy, has demonstrated a low incidence of cardiac events, which were generally reversible in most patients. And this study, actually, this approach or this treatment given sequentially after chemo and radiation is actually a breast cancer, approach. But the reason I bring it here is to say, even for those patients having trastuzumab for 1 or 2 years, followed by chemo or radiation, the effect is reversible. In colorectal cancer, trastuzumab and HER2, which is the small patient portion of the patient that's eligible to treat with trastuzumab, usually the utility or the length of the treatment doesn't go beyond a year in general. ASCO actually established a guideline for prevention and monitoring of cardiac dysfunction and cancer survival. And they have shown that risk of cardiac dysfunction related to trastuzumab is increased with the following risk factors. And these include multiple cardiovascular risk factors, including smoking, hypertension, diabetes, dyslipidemia, and obesity, during or after completion of therapy. Another risk factor actually is older age, older than 60 years of age at cancer treatment. And finally, compromised cardiac function. When we start your treatment and a patient have a borderline low ejection fraction or have a history of MI or valve disease, usually those patients are at a higher risk of side effect of trastuzumab or HER2-based therapy. ASCO guidelines recommend actually a comprehensive assessment in the cancer survival who have, by doing actually history and physical screening for cardiovascular disease risk factors. Also, they recommend modifiable risk factors like smoking, hypertension, diabetes, or dyslipidemia and obesity to be actively managed and intervene as needed. In any time a patient develops sign or symptom of cardiac dysfunction, we typically, and the norm is to do an echocardiogram, and for some patients who can do that, cardiac MRI is preferred over a mammogram scan. So that's the highlight, the most side effect or systemic therapy that might be seen for a long-term survival for colorectal cancer patient. And it just like I want to highlight also one comment here that in addition to monitoring side effects, and the management of colorectal cancer patients, usually the surgeon stops seeing those patients maybe 1 or 2 years later. We monitor those patients up to 5 years of survival, but after 5 years, we see them once a year. So the primary care physician and colleague going to be seeing those patients more often than us. Even though we say that the risk of cancer recurrence is slim after 5 years, it's still not zero. So in addition to talk about side effects of systemic therapy for colorectal cancer patients, we also need to be monitoring those patients for any sign or symptom of a disease recurrence. And they should be having colonoscopy and should be monitoring. And any sign or symptom should be triggered, imaging and referred back to oncology at appropriate time. With that, thank you so much for your attendance and have a good day.
Thank you, Dr. Abdelrahim. Our next speaker is Dr. Diego Marinas. He's a colorectal surgeon at Houston Methodist Willowbrook, and he'll be speaking today about the impact of surgery on colorectal cancer survivorship.
Thank you, Dr. Asneola, and thank you everyone for being here virtually. I control the slides. Let me see. Okay, here are the objectives for the next 15 minutes. I would like to talk to you guys about how to take advantage of a multidisciplinary approach, including primary care physician, in the recovery of patients after surgery, and how to manage some of the sequels, so to speak, of surgery and other treatments. So when I was a medical student, I became interested in surgery because it was just impressive to me to see how we could remove a segment of intestine, hook it back up, and make it work almost like it was like nothing happened. And then in residency, I became passionate about the recovery of the patients and what things we could do to get them back to their functional status as quickly as possible. And instead of having the patient go to a nursing home, a rehabilitation facility, to get them back home. So 7 years ago, at my home institution, which is Houston Methodist Willowbrook Hospital, I implemented an enhanced recovery, a formal enhanced recovery after surgery committee, which I still lead, and we started implementing things that separately, or interventions that separately have been proven in studies to enhance the recovery, to improve patient satisfaction, decrease complications, improve results, and these factors can be before surgery, in surgery, or after surgery. And some of the things to consider when the patient is going to have surgery is that the patient comes to us already debilitated in certain way and in certain degree, and everyone is different. But let's say the patient got preoperative total neoadjuvant treatment with chemotherapy, with radiation. So the patient is having maybe some side effects from the chemotherapy. The patient has lost about 20 pounds in the last 6 months from having the cancer, etc., older age, frailty. And then we subject the patient to the additional trauma of the surgical intervention, and we set them back even more. And we're doing all the minimally invasive approaches. We're extracting specimens through the rectum. We're doing transanal total mesorectal excisions. We are every day trying to push the limits on how minimally invasive, how to lessen this trauma. But still, the patient is under anesthesia for 2 or 3 hours. They're going to have decreased appetite for the next week or two, and they're going to be with low energy for the next week or two. So these are the things that we were focusing on. And in the preoperative area, and this is when I would like to get primary care physicians involved as well, is to counsel the patients and tell them, you don't have to be NPO after midnight, the night before surgery anymore. We're actually providing the patients with protein shakes to take starting 5 days before surgery, and these are provided to them in the preoperative visit. So that way they're less malnourished during surgery and after surgery. We are doing regional analgesia in the form of tab blocks that was already mentioned before. Intraoperatively, we're limiting the amount of IV fluids, we're controlling temperature, we're doing several different interventions. Post-operatively, we're feeding the patients early. When we used to wait for the patient to have bowel movements, when I was a resident, to be able to feed them, now we're feeding them right away. We're letting them walk right away, and several other interventions. So what else can we do? One of our main focuses currently on the Enhanced Recovery Committee is prehabilitation, which includes 3 factors: psychological, nutritional, and physical endurance. Psychological being the anxiety of the patient having been diagnosed with cancer and having to undergo all these treatments, and that anxiety has been proven to set them back even more. Physical endurance, where we have a trial going on where we measure the patient's physical capabilities with a simple walking test, and then recommend some interventions before surgery. Instead of waiting for after surgery to get rehab, we're doing prehabilitation. Avoiding dehydration, especially with patients that require either a temporary or a permanent ileostomy and they're elderly, they can easily get dehydrated. And so that's when primary care physicians are going to be seeing those patients in the office, we need to be screening for dehydration and electrolyte imbalances, and then send them to the infusion center before they have to get so dehydrated that they go to the emergency room. We can act early and send them to the infusion center for 1 liter IV fluids. Narcotic avoidance, very important in the recovery of the patients. Of course, the pain has to be controlled, but in elderly patients, narcotics contribute to delirium and other side effects, and nutrition we talked about. Okay, some specific scenarios. A patient has had a right hemicolectomy for cancer, and now in 50% of patients, the ileocecal valve was competent and was keeping contents from the small bowel from going directly into the colon so quickly. So now the colon is more exposed to bile acids, which were previously absorbed in the terminal ileum, and now the patient's having diarrhea. Some treatments for this: do nothing and wait 12 months. That doesn't sound very appropriate. Low-fat diet can help, and some medical treatments such as cholestyramine, which bind the bile acids and improve their bowel function. Now, we're also always, when I was a resident, about 10 years ago, we would say tumors in the rectum that are below 8 centimeters require an APR, which is removal of the whole rectum, anus, and a permanent colostomy. Now we're pushing the limits, and also we're decreasing the margins. The margin that we needed distally back then was 2 centimeters. So we're pushing the limits of sphincter-saving surgeries, doing transanal techniques, doing minimally invasive techniques, and all those nice things. But at the same time, we're leaving less rectum behind with a colon anastomosed almost to the anus at times. So we have something called low anterior resection syndrome, and it's when the patient is affected by having very little rectum left behind, with symptoms such as multiple frequent bowel movements, seepage, incontinence, clustering of the stool, urgency. There's a consensus on this. Risk factors, everything that the patient has gone through and that they're going through. Radiation therapy, a low anastomosis. There is an assessment. We don't use it routinely because we already know how to counsel the patients. Okay, if the patient is female, they're gonna get an anastomosis at 3 or 4 centimeters from the anal verge. They're older, they have had radiation, so we counsel them that they are higher risk for low anterior resection syndrome. Now, for fecal incontinence after surgery, there are multiple different scores. We don't need to dive too deep into these. But asking the patient about seepage, accidental stool leakage, accidental gas leakage is very important, because they can develop some of these symptoms a year, 2 years after surgery sometimes, and they think it's normal because they had surgery for rectal cancer or because they're older. And so screening for these symptoms is important because we have good treatments for them. Okay, here's another score in another questionnaire to screen for that. But just asking the patient is usually very helpful. Of course, dietary modifications first, high fiber foods, medical treatment, antidiarrheals, pelvic floor rehabilitation. So when the patient is having some of these symptoms, fecal incontinence, seepage, etc., pain after a low rectal surgery, it's best to send them back to a colorectal surgeon that has interest in pelvic floor therapies. I have a special interest in this as well, and I perform anal manometry in my office, rectal sensation tests, endoanal ultrasound, and we have a dedicated pelvic floor a pelvic floor physical therapist at our institution that is very familiar with these patients. Transanal irrigation, not ideal, but some patients it works for them. You know, I have a patient that has an appendicostomy, which is just a little opening in the appendix through the abdominal wall, and she irrigates every morning before getting out of her house with 2 liters of water through there, goes to the bathroom, and she's good for the rest of the day. And she rather do that than go to a permanent colostomy. Sacral nerve stimulation has been around for a couple of decades, and in my experience, it works really well for patients with fecal incontinence and seepage and incontinence after rectal surgery. It stimulates. It's as you can see here with my mouse, I'm going to point at the S3 foramen. That a wire gets placed there and it gets hooked up. I like to tell the patients it's like a pacemaker for the butt, but it's smaller, and it goes just under the skin, and it stimulates the nerves so that we can have better awareness on when the patient needs to start heading to the bathroom. And patients that used to stay home, avoid social situations, always trying to be aware when they're outside where the nearest bathroom is, wearing a pad, wearing a diaper. Now, after this procedure, I've had many patients that come wearing jeans, and that's the first sign I can tell the patient is doing better. If they're not wearing sweatpants anymore and they're wearing jeans, they're good. And they've gone on vacations now and stuff. So, and of course, last resort, creation of a colostomy. Like I said before, patients with ileostomy, things to if you're detecting the patient has dehydration because of a high output ileostomy, and I like to tell the patients, if you have more than 1,500 milliliters a day for 2 or more days, you might be getting dehydrated. If your urine is getting darker, your mouth is getting drier, etc. And we can try Imodium. In the liquid form works better for patients with ileostomy, because if not, we see the pill in the ileostomy bag undigested and it didn't do anything. Tincture of opium, which is harder to find nowadays, but still around. Loperamide, dietary changes is patient-specific, because for some patients, certain things work better than others. And I have some patients that tell me that eating marshmallows really bulks up their stool, and we want a mushy consistency in the ileostomy bag instead of a liquid consistency. Saline infusions we talked about, and we also have a study going on about early ileostomy reversal. One of the studies that was being done, instead of closing the ileostomy after the temporary ileostomy after 6 to 8 weeks, they started closing it after 10 days. They finished that study early because the patients were developing complications. So we have another one going on about still reversing it early with minimally invasive techniques, but not that early. And then that way the patient gets less morbidity from the ileostomy. So in summary, we can have a great impact in how patients recover from surgery, and it's good to screen patients for these symptoms of a low anterior resection, malabsorption, anxiety, depression, etc. And we can all work as a team to get the patient to the best functional status possible after surgery. Thank you.
Thank you, Dr. Marinas, for that great summary of survivorship issues around surgery in patients with colorectal cancer. Our final speaker today is Dr. Andrew Farrick. He's a radiation oncologist here at Houston Methodist. He works very closely with our colorectal team, and he'll be talking today about the implications of radiation therapy in patients with colorectal cancer.
Let's see. Thank you, Dr. Asnola. Let's see if I can figure out how to work this here. Okay, so Andrew Farrick, I'm in the Department of Radiation Oncology here at Methodist, as Dr. Asnola mentioned, and I focus, one of my focuses is on gastrointestinal malignancies, so I take care of most of our rectal cancer patients. I don't have any disclosures. I'll try to keep this pretty quick. Some of this has been touched on, and I want to leave some time for questions, but give a quick introduction to terminology that you've already seen, some indications for radiation therapy, and then the biggest part will be focusing on long-term effects of radiation therapy. So typically, as Dr. Hawk mentioned, we give radiation therapy preoperative, and he gave you some of the data for that. Just to give you some terminology, refresher here, it's hypofractionation is also referred to colloquially as short course radiation therapy, and that's typically 25 gray and 5 fractions, so bigger doses, shorter duration, and that's given without radiosensitizing chemotherapy. That's compared to what's most commonly given in the United States, which is conventionally fractionated radiation therapy or long course radiation, and that's what people more commonly think of going to the radiation clinic for several weeks. So this is 5.5-week course, 50.4 gray over 28 fractions, and that one is given with 5-FU based chemotherapy. Rarely we give postoperative radiation therapy, and that's always given with conventional fractionation, as you can see there. So who receives radiation therapy? Very occasionally, and this is rare, we'll treat a low T2 or T1 tumor that is abutting the sphincter complex in patients that prefer organ preservation. I had one recently completed with a combination of total neoadjuvant therapy and radiation therapy. We've moved to closer to 35 to 40% complete response rates, and watchful waiting is a potential option for patients with very low tumors wanting to avoid a colostomy. But patient selection and close surveillance is very important in these patients. The bread and butter of what we treat, though, is more locally advanced rectal cancer, T3 or T4, and node-positive rectal cancer. So that's typically who we'll see in the standard radiation clinic. And then also we treat oligometastatic patients, like the ones Dr. Esnola was referring to, with limited liver metastases or lung metastases that can still be treated with curative intent. Typically, the oligometastatic patients these days more and more will be treated with a short course radiation technique. That way you can allow for continued systemic therapy or get them quicker to surgery, that sort of thing. And then I have palliative, which we often do for symptomatic patients, but typically they're not going to experience late toxicity, so that's why I have that X'd out there. So what's the reality? The worst complication in the treatment of colorectal cancer is a local recurrence. Dr. Haas kind of touched on this, but it's really a miserable experience for the patient, and there's not a lot that we can do as physicians to improve their symptoms. We can try nerve blocks, we can try high-dose opioids, but really these patients are miserable. So it's really important and can't be emphasized enough, the importance of minimizing a local recurrence. So despite no overall survival benefit to radiation, the local recurrence benefit is critical. For these patients, their median survival is short, and they have very poor quality of life if they do recur locally. The Swedish trial, this has been touched on, but basically this helped establish radiation therapy as a standard for locally advanced patients, and this one showed both an overall survival benefit and local control benefit, but this was in the pre-TME era, as was discussed. Here in the Dutch TME trial, this is patients with TME surgery, and once again, there's still a 50% reduction in local recurrence, so this just shows why radiation plays a significant role for locally advanced rectal cancer patients. But what I wanted to mostly touch on here is that that does come with a cost, and that needs to be considered in patient selection. But these patients, this is all grade toxicity, so some may be more mild or bothersome types toxicities, but nonetheless, you can see that there are high rates of complications long-term related to receiving radiation therapy for locally advanced rectal cancer. And you can see there's more incontinence both at day and night, more anal mucus loss, more blood loss, and increased use of pads related to the radiation treatment. The German Rectal Cancer Study Group compared pre- and post-op radiation. This was also touched on, but I really wanted to just focus on the late effects here. So any grade 3 or 4 toxic effect that's really significant, severe side effects are way more common in the post-operative setting, so we really want to avoid delivering radiation in the post-operative setting. This was important because we know we overstage about 15% or so of rectal cancer patients with either endoscopic ultrasound or nowadays mostly MRIs, but there is some overstaging, and so sometimes you want to maybe try to pick out those patients that might be overstaged and avoid the radiation and the related side effects. But if you do and you get that wrong, then the patient needs post-operative radiation therapy, and they may experience significantly more severe late effects, as you can see here, 24% versus 14%. So patient selection, multidisciplinary discussion prior to surgery and that sort of thing is really important, and I think we do a great job of that in our multidisciplinary conferences in a prospective fashion. So the late GI complications, this is really the most significant complication. That can be persistent diarrhea. Some of this has been touched on already, treatment with Imodium, dietary modifications, or pelvic PT, and I do work very closely with pelvic PT specialists. This is really for any patient receiving any form of pelvic radiation. It doesn't have to be for rectal cancer, but they can experience similar side effects. Anastomotic stricture, again, more common in a postoperative setting, so we prefer pre-op, but it can still happen, and that may require dilation or surgical repair. Proctitis is really less of an issue in patients that undergo surgery, so this would be something more common in a patient that has watchful wait strategy, but in your standard patient that undergoes total mesorectal excision, afterwards you're actually removing the irradiated rectum, so there's less issue with proctitis. If they do, and the most complex patients of these are patients that are also on some sort of anticoagulation for cardiac issues or whatever, and you run into this trouble with rectal bleeding and anticoagulation, and our GI colleagues can help us with APC and that sort of thing to try and minimize the bleeding telangiectasias in the rectum. And then a rare complication is bowel obstruction related to either surgery or radiation. Late GU complications are relatively rare. That's just due to the field that we use for rectal cancer. We don't really include much of the bladder. Guys that have significant lower urinary tract symptoms coming into radiation may have some acute obstructive symptoms. We keep our eye out for that, but it generally doesn't translate to significant late effects. That's just related to the radiation field. We're mostly posterior in the pelvis. This is something that's really under-talked about, the sexual dysfunction related to treatment of rectal cancer. Unfortunately, the most studies are in men focusing on erectile dysfunction. There's hardly any studies on late complications in women. But the best study is this Norwegian study looking at erectile dysfunction in men after the treatment of their rectal cancer. And you can see they have, if they received radiation therapy, they already have a baseline rate of poor erectile function, and then that's worsened by the radiation treatment. Ability to have an erection strong enough for intercourse and that sort of thing is diminished. So things to look out for in the primary care clinic in these patients is low T, obviously, and that, you know, I think people are looking out for that anyway, but that can be modifiable. Women who had pelvic radiation, the ovaries are exquisitely sensitive to radiation. We're seeing younger and younger colorectal cancer patients, so you need to screen for ovarian dysfunction, and that may be modifiable and help with many things like vaginal dryness. That can also be treated with low-dose vaginal estrogen creams. I can't overemphasize the importance of pelvic physical therapy for both men and women after pelvic radiation. And the biofeedback that Dr. Marinas was talking about can really help them improve their pelvic floor health. And women, this is often forgot about at many radiation centers around, but every woman that receives pelvic radiation, including for GI causes, should receive a vaginal dilator at the end of their treatment course and be taught on the reasoning for that. We talk about it a lot in our clinic and try to get them comfortable with it. I also try to make it not something that's so daunting that they just decide not to do it. So I give them something that's reasonable. 5 minutes once a week is better than nothing, that sort of thing. And then hopefully they will actually use the dilator and minimize their sexual dysfunction. Bone health, something nobody talks about, but it's really important for patients that receive pelvic radiation of any kind, definitely for rectal cancer. But radiation can contribute to bone demineralization, especially if patients also have compounding ovarian dysfunction or postmenopausal or have low testosterone. For most of my patients that come for rectal cancer treatment, obviously we're trying to get their cancer treated, and that's the primary focus initially. But at their first follow-up visit, I will try to get them a bone density as a new baseline, start vitamin D and calcium supplementation, and then either work with their primary care doctor or endocrinologist to treat discovered osteopenia or osteoporosis to reduce the risk of pelvic insufficiency fracture. Second malignancy, now this is over talked about and really not seen as much. The risk of second malignancy related to pelvic radiation is actually relatively low. If you screen the colon, most secondary malignancies for pelvic radiation are actually colorectal cancers. That's less of a case in patients getting treated for colorectal cancer because they're usually screened well. But screening after pelvic radiation is really important. It should begin 5 years after radiation delivery, regardless of the age, or now beginning at 45, obviously. All male rectal cancer patients should have a PSA prior to initiating radiation therapy, and that's because prostate cancer is common and it's really complex to come back and try and treat prostate cancer after you've already treated a rectal cancer, so you can actually treat both simultaneously if you need to. And then Lynch syndrome screening, which we do as a reflex test here, but that's not done universally, is really important to keep in mind because endometrial cancer, as Dr. Singh mentioned, can coincide with colorectal cancer in Lynch syndrome patients, and you need to be screening for these things. So just thank you, Dr. Arrington, Dr. Esnola, and we're happy to take any questions for the remainder of the time.
Thank you very much, Dr. Farich. So this concludes the presentations for the day. We do want to have a brief question and answer period for any folks that are still online. We've got a couple questions that were submitted that we wanted to go through with the group. And we've got Dr. Arrington, Dr. Marinas representing surgical oncology and colorectal surgery, as well as Dr. Mather representing gastroenterology. Dr. Farich will stay here with us, and Dr. Khalil will join us remotely for any questions that you folks may have. We'll go ahead and get started. Actually, one of the questions that we had was regarding the role of radiation therapy, and I'm sorry I did not get a chance to discuss that in the management of patients with liver metastases. Dr. Farich, I was wondering if you can talk to us a little bit about the growing role of radiation therapy compared to, let's say, ablation or surgery in the management of liver metastases.
In general, colorectal cancer metastases are a little bit more radio-resistant. That's related to the amount of chemotherapy they see before radiation is delivered compared to breast cancer or other more common liver metastasis. So in general, as Dr. Esnola mentioned, ideal situation is get these patients to surgery if possible. Ablation is great for small tumors, less than 2 centimeters or so, but as you get larger than that, the local control actually wanes a little bit, and we can deliver stereotactic radiation to these lesions. There are certain lesions in difficult locations for either surgery or ablation, and stereotactic radiation can address these as well. So it's a liver-directed therapy that can be delivered with a curative intent for oligometastatic patients.
Thank you. Question for Dr. Mather. There are a lot of questions about Cologuard and colonoscopy, and what, in your opinion, is the most appropriate way to start colorectal cancer screening in younger patients as compared to, let's say, older patients in the primary care setting?
I think that's a great question. I mean, this is exactly where the path of screening starts in primary care. So for me, how I position colonoscopy versus Cologuard, which is a multi-targeted stool DNA test, is that I think if the patient is healthy, doesn't have any contraindications to having an invasive procedure like cardiovascular health, pulmonary health, their mortality is good, especially you're looking at your younger patients starting at 45 or younger. So colonoscopy should still be offered because of the long-term benefit that you can get with 10-year, like the mileage I talked about. But Cologuard, you're going to be doing it every 3 years. So cumulatively in the 10-year process, you're getting 3 Cologuard tests. And if any of them turn positive or false positive, they're then additionally having a colonoscopy. So you have to explain that to the patient so they understand the burden, the financial burden, the multiple testing burden versus, yes, it's kind of more invasive. Yes, there's anesthesia. Yes, there is prep associated with. But in all of those categories with colonoscopy, we've also made a lot of advancements where it's not as bad as it used to be. There's a lot of misinformation that used to be from when the Go Lightly era was, moderate sedation era, and the length of treatment, waking up in the middle of their colonoscopy, bad experiences. So those have gone away with the advent of propofol use, the low volume bowel preparation, and of course a good discussion. And our techniques have improved. We're using carbon dioxide in colonoscopies versus air, which is used to lead to post-procedural cramping and distension complaints. So overall, the patient experience is much better. So if you talk to these patients post-colonoscopy, they'll say, oh, I don't know why I was so afraid of this. And a lot of it has to do with what they're reading online and blogs, maybe one or two bad experiences that you come around, but overall, it's a very low-risk procedure. And done, again, in a experienced endoscopist, you should have a very low risk. So the benefit of an invasive test is still better. So I still go with a colonoscopy first. Now, if you have a patient who is maybe undergoing another malignancy treatment or in heart failure, getting hospitalized frequently, difficult to go under anesthesia, or you don't have cardiac anesthesiologists available at your institute to support some of these procedures safely, then you can offer them a Cologuard as a space holder, and then as soon as their health improves, I say bring them back for a colonoscopy next time. So that's how I would position it.
Great, thank you. There's a question about the role of liver transplantation in the management of hepatic colorectal metastases, and I'm happy to answer that. So essentially that's considered an experimental procedure at this time. We do have a clinical trial here at Houston Methodist. We do have individuals that have disease that is not resectable, and some of those individuals can be considered for liver transplantation. It's a very specific subset of patients, but that's something that can be considered, and we do have the capability of doing that here at Houston Methodist. A question for Dr. Khalil, who I believe is online with us, regarding what is the appropriate time to pass a patient back to the primary care physician after their treatment for colorectal cancer? Is it within 2 years, within 5 years? And what are red flags that a primary care physician should keep an eye out for that alerts us that we should send that patient back to their initial caring treatment team?
Yes, thanks, Dr. Snola. So yeah, that's a very good question. So typically, patients have a program of surveillance after they're done with their treatment that includes scheduled imaging studies, lab tests, clinical examinations, colonoscopies. And as medical oncologists, we typically follow these patients for at least 5 years. Typically, the first couple of years are the most critical ones, but most of the time we keep following them for up to 5 years. After which, the decision is made depending on the support system for the patient, and after discussion with them, it can be appropriate at that point to transition them back to their primary care physician with a clear plan about what follow-up colonoscopies they might need, any signs or symptoms to monitor for. That could include clinical symptoms of recurrent cancer, abnormalities in their lab finding, they're developing recurrent iron deficiency, anemia, etc. In some situations, and depending on the setting and on the patient, we sometimes continue to follow these patients for a longer period of time if we are concerned about their particular situation.
Thank you. And a similar question for Dr. Marinas and Dr. Farage, and it's relating to, you've mentioned that many of these folks will have sequela from their surgery and their radiation treatment, specifically rectal dysfunction. At what point is it appropriate for us to send those patients back to the treatment team, and should we send them back to the surgeon, the radiation oncologist, or both?
I would say sending them back to the surgeon would be definitely adequate. I would be interested to see if the radiation oncologists agree with me, but yeah, we'll be happy to see those patients as soon as they start having any symptoms that are affecting their quality of life.
Yeah, I agree. I think sending to the surgeon would probably be the best approach, but we're happy to answer any phone calls or happy to see the patient, obviously, if you think it's a radiation-related side effect. But a simple phone call, we can usually give you a lot of help on any patient that's previously received radiation therapy.
Thank you. And a question for Dr. Arrington. It's not uncommon for us to get pathology reports back after our patients have appendectomies, and by that token, oftentimes they'll find an incidental tumor within the appendix. Which patients with appendiceal tumors should we refer to a surgeon for further evaluation, specifically to a surgical oncologist for further evaluation? And what is the role of HIPEC in that setting? Do they need, is it always indicated or only some of the time?
So first of all, I'm happy to see any abnormal pathology reports for appendix because it really depends on what the abnormality is, how far away it is from the staple line, what that answer is. If it's all contained within the appendix, if it's a low-grade appendiceal mucinous neoplasm, or even a neuroendocrine tumor well away from the base where the appendix is cut off from the cecum, I may just see the patient and say, you're great, you don't need any follow-up, or you need a one-year scan, and HIPEC would not be indicated in those situations. In the cases where there's mucin or there's a perforated appendicitis with that finding, where there's mucin within the abdomen or around the appendix, that might be an indication for a HIPEC or very, very close surveillance. But again, I can't reiterate. If you have any questions, please just send. It's easier to have that discussion with the patient so everybody knows the treatment plan and their options.
Okay, great, thank you. Well, it's 12:30, so we're going to adjourn. I want to thank all our speakers today. I think this has really been a very sort of content-rich symposium. I hope it's been very helpful to the participants today. We've made our effort to make sure that the content is geared towards primary care physicians. Again, we're fortunate in the sense that Houston Methodist Health System has really a terrific team of surgical oncologists, colorectal surgeons, medical oncologists, radiation oncologists, and gastroenterologists really at all of our sites. And so I think that as a primary care physician, you should have a very low threshold to reach out to any of those individuals. If you have a patient with colon cancer, with rectal cancer, our goal is to try to get those folks into our system as quickly as possible. We do feel that we provide world-class care. And we're very patient-centered, and I think that's one of the ways in which we really strive to make sure that we provide excellent service, both at the patient level and to you as well. I also want to just as a quick plug, this will actually be an ongoing series of symposiums moving forward. Our next symposium will likely be focused on breast cancer, and we hope to try to launch that over the next 6 months or so. But expect to see a series of these potentially on a quarterly or biannual basis, focused on common cancers like colorectal, breast, lung, melanoma, pancreatic, gastric, and so forth. Again, we hope that these are helpful. I do ask that you please reach out with any comments, suggestions, criticisms. We want to make sure that these symposiums are geared to primary care physicians, that you find them to be helpful, that you find the content to be appropriately detailed, but not overly technical. So again, I want to thank all our speakers today. I want to thank everyone who's participated today. I hope it's been a helpful day, and have a safe weekend.